الحزام الناري يترك الكثير من الناس يعانون لأسابيع. هذا الطفح الجلدي يجعل ارتداء الملابس أمرا مؤلما، والنوم مأساة. ولكن هذا ليس أسوأ ما في الأمر. هذا الألم المنهك يجعل الناس يفوتون اللقاءات ووقت العائلة، وحتى اللحظات التي لا تأتي سوى مرة في العمر. ولكن حتى هذا ليس أسوأ ما في الأمر. الأمر الأكثر إحباطاً بشأن الحزام الناري هو إنه من الممكن منعه. لقد طفح الكلمة. كفى يعني كفى. يكفي أن شخصاً واحداً يعاني من الحزام الناري. هو كثير جداً. لقد حان الوقت لأن يسمع كل مريض عن الوقاية من الحزام الناري. معاً يمكننا المساعدة في حماية الملايين من هذا الألم الممكن تفاديه.
Can we
الآن
hold the
هو
video
الوقت
for a
المناسب.
second, please, since we're
السؤال:
starting?
إذا كان بإمكانك منع المعاناة بسبب الحزام الناري، لماذا لا؟
Okay. Good afternoon, everyone, and welcome again into our geriatric online conference. As we're starting this third session that will be about the advances in the neurocognitive disorder, I want to welcome our moderator, Dr. Afaf Al-Blawi. Dr. Afaf is a consultant of internal medicine and geriatrics, hospice and palliative care medicine. She's the head of the scientific committee at the Geriatric Saudi Society, an assistant professor at the University of Tabuk, Kingdom of Saudi Arabia. We welcome you, doctor. And I think we have also our guest from a different time zone. So you can go ahead, Dr. Afaf. Thank you.
Thank you, Dr. Tarad and Dr. Samah for moderating the previous session. Dr. Tarad will continue moderating this session alongside me. Session 3 is about advances in neurocognitive disorders. It's my pleasure to introduce our next speaker, Dr. Mikhail Kogan, a geriatrician and associate professor of medicine at the George Washington University School of Medicine and Health Sciences, and medical director of the GW Center for Integrative Medicine. Dr. Kogan is internationally recognized for his expertise in integrative medicine, healthy aging, and patient-centered geriatric care. Today, he will be delivering his lecture titled Integrative and Supportive Approaches in Dementia Care. Dr. Kogan, please, and the audience, please welcome Dr. Kogan. Join me in welcoming Dr. Mikhail Kogan.
Well, thank you so much, esteemed colleagues. It is a little different time zone, so we're still deep at night here, but I'm sorry I missed some of your earlier presentations just to get to sleep, but I'm very honored to present, so I'm going to go ahead and share my screen and start the slides. So I have been doing this work for quite some time. I do have some disclosures, some of my books. I'm going to be using some of the information derived from the books. I'm also involved in a number of startups, and I'm going to review at least one of them during this presentation. So why integrative geriatrics and what is it? It is a new field of medicine that advocates for a whole person, patient-centered care, primarily using non-pharmacological approaches first, and only after they fail do we introduce additional, more medical interventions. And one way to think about integrative health in general is to imagine that for a healthy individual to stay healthy and be fully productive, we need not just our medical system, but we need to really have a core functioning that is rooted, just like this tree, into the community, good sleep, good food, good environment, good movement. And quite often in medicine, we think that when one of the branches on the tree starts to get diseased, that the treatment is to simply deal with the branch. And we often forget that the actual starting point of diseases is often based in the root causes, and pun intended here. So with that in mind, I'd like you to introduce you to two of my patients. So the first patient, Phil, and I do have permission to share all this with the family. So I've met Phil in 2008 when he, at that point, was already moderately progressed. In fact, he had multiple hospital admissions at that time, and when he was discharged to the community from yet another hospital admission at our hospital, the family chose hospice. So this is 2008. This is before I started using our integrative approaches on every patient with Alzheimer's and in more structured ways. So this was simply adding additional B vitamins, using an aggressive anti-inflammatory approaches, and that gave Phil almost 12 additional years of living from basically diagnosis to death. He had nearly 20 years of Alzheimer's, and he was for 10 years on hospice, basically, and this was unheard of. So this first case triggered in my mind a desire to learn more, and also kind of this deep dive into what else can we do in addition to kind of a standard of care of monitoring supportive care and a couple of medications. Years later, I had a first case of reversal of Alzheimer's, and this is Larry, and he was a very decorated war veteran and very, very strong man. When I met him, he was already in his late 80s. And what happened with him is he was rapidly progressing. He first presented to our memory clinic with a relatively mild disease, but at that point, he already struggled with basic math. He couldn't drive anymore. And when we were talking to him about his diet, what came up really quickly is that he was consuming a lot of really large fish, particularly swordfish. Swordfish is very high in mercury. And so Larry was very toxic. So what you're seeing here on the left is one of the what's called the functional medicine test, not the regular test for mercury, showing that he had high elevation, particularly of an organic form of mercury coming from fish here on the top left. And on the right, you're seeing a comparable table after we had him stop eating large amount of seafood and also supported his system with number of detoxifying nutrients. So he had a rapid decline in the mercury level, and with that, he had an improvement in the cognitive scores. Unfortunately, in his mid-90s, he deteriorated after several strokes, but he had a pretty dramatic and quick complete normalization of memory, full reversal of all the symptoms, going back driving and not having any additional symptoms. So the case was so striking that we published this back in 2020 in Complementary Therapies in Medicine, and you have a link and you can look up all of the details of the case. So this is how my work has begun here. And now I'm going to show you in a few minutes how do we manage this today. Of course, many of you have been familiar with a recent publication in Lancet. So this is the Commission on Dementia Prevention, probably a gold standard, I would say, at least in Europe, but increasingly so in the United States, on how to prevent nearly half of all the cases of Alzheimer's. And I'm going to take this further. I'm going to tell you that we should be using the same exact model, not just for prevention, but also for treatment of dementia. So Lancet identified 14 core drivers. These are physical inactivity, smoking, alcohol, air pollution, etc. So things are here on the list. So the problem is not necessarily that we're not understanding this, we do, but how do we make this into an actual model of delivery of care? And so one of the first models have been established by Dale Bredesen. We do use partially his protocol, partially what we do is a little bit different. But this is the first randomized controlled trial that's about right now going through the peer review. This is preprint, but I'm allowed to share this. And I'm going to show you, this is a small study. You only have 75 patients, 50 patients in the actual group, and 23 patients in control group. The ApoE4 levels were about the same in both groups. But when you look at the results of using this precision medicine, and I'll explain in a second what exactly this is, you can see a pretty substantial difference. This is CNS vitals, neurocognitive indexes that are dramatically better in the treatment group versus standard of care, as you would expect, going to continue gradually decline. Also, the additional data more on composite memory and also on the Montreal Cognitive Assessment. This is the MoCA test. So you can see there's a pretty big difference in all of the markers. Now, one thing is standard of care MoCA improved partially because this is relatively early disease and some of the patients can memorize the test. So we do observe this in the first couple of years. Patients sometimes slightly improve. So how does the protocol look? So you have to address multiple things at the same time. You start with the lifestyle modifications, the same ones highlighted in the Lancet report, but you don't stop there. So you have to look at every possible driver, toxins, sleep, hormones, nutritional deficiencies, and then you add neurostimulation on top. The sample protocol going to look very sophisticated. I don't have time to go through details of this. This is just basic example of what some of our patients are getting. The diet gets changed quite dramatically. We don't adhere to just one diet. Some of the protocols in different institutions adhere to particular diet. Over the last 10 years or so that we've been doing this work, we've learned that unfortunately one diet doesn't work for everybody, and you really have to diversify and apply a variety of different approaches. So for some patients, Mediterranean diet works well. For some, it has to be really strict ketogenic diet. In short, what works for the patient is what works for the patient. And we do, however, use quite structured various exercise programs that include aerobic endurance, but also online Tai Chi classes and other things. Multiple different supplements. This is not a complete list. This is just for as an example. We do address hormonal abnormalities. Not every patient needs this, so you have to continuously assess and reassess levels on blood tests and modify the supplementation of hormones accordingly. Every patient gets sleep tests and very aggressive assessment of oral health. If the patients do have a toxicity from mercury-containing fillings, then those fillings are getting removed with a special dentist, what's called biologic dentist. So the removal of mercury fillings is safe. And then there's a variety of neurostimulation applied. Again, this is not a complete list. We do use in our clinic special software that uses 40 hertz light and sound therapy delivered through the iPad or an iPhone. But there are other methods now. There's a red light therapy and etc. We don't have time to go into detail. So this has just got accepted for publication in Global Advances in Integrative Medicine and Health. And the data is that about 73% of patients either improved or they don't progress at all. And some of these patients now have been followed for close to 10 years. I showed you 2 cases, but there are a lot more. What's most difficult about the program is a very high level of dropouts. Reason is very simple. It's a very logistically difficult program. When we sign patients in, they have to have a caregiver and they have to commit to 2 or 3 hours roughly per day of additional work to get this done right. Reasons are quite straightforward because we do engage them in so many different activities. If they're not capable of committing, they're not going to succeed. So they're going to drop out, unfortunately. And also because of this, of the complexity and the time required and the number of coaching hours and the team engagement, we can't have this program at the moment covered by any insurances in US. But I do hope that with some of the political changes, we're going to see a shift because this program actually costs a lot less than a current care for Alzheimer's. The estimate cost of this is about $10,000 to $12,000 a year compared to even one infusion medication like Leqembi will cost at least 3 to 4 times this amount. So I think the price point of this is very attractive for the structures. So now I'm going to show you a couple of selected cases. So these are the 2 cases. Again, this ones actually haven't been published just yet. We're working on publishing this specific cases. So there's 2 women. One is a little bit younger than the other. Both were progressing. Multiple different drivers in the patients who is 62. You can see that she had a thyroid, hypothyroid, sleep apnea, So her NeuroQuant, and I'm not sure that if everybody's familiar with this, but it's a standard of care now in US. When we get MRI of the brain, we use the software called NeuroQuant that predicts exactly the sizes of each parts of the brain. In case of this patient, her hippocampal volume was very, very low, as you can see at 1%. And what happened with her after the program, so this is 2 years after the program, her hippocampal volume increased from 1% to the 63%. So we now routinely observe this dramatic of the improvement when the treatment applied appropriately. It has not been seen before, so it is revolutionary for sure. This is still yet selective cases. We don't achieve this level of improvement in every single patient. Percent of the selective, we don't even know why some patients improve this dramatically and others don't. Probably because if we catch something relatively early, the drivers, and capable to reversing them, and the patient is young and still has a good neuroplasticity, they're capable of achieving this. Coaching is critical. Part of the reason is there's a lot of changes that patients has to do. Their protocol is sophisticated. They have to follow it. There's a lot of inertia when people changing lifestyle. So you have to really support them. Until very recently, this has been done exclusively through additional manpower. So we would have a team of several coaches working with clinical team, continuously supporting each patient. We changing this. You can imagine that AI is bringing a revolution here. So we are currently finishing up formation of this company called Boston Cognitive that basically going to fully automate the coaching aspect at no cost to the patients. We're figuring out how this will be monetized and delivered to the broader population. Currently, we're trying to start this just at one clinic, and then we will expand this. So what we've observed in the last roughly 10 years by now on over 100 patients, that no longer Alzheimer's is a predictive progressive disorder. It's now a spectrum of outcomes. Some patients progress like you would expect. Some patients stabilize, and minority of patients actually improve to the point that their function comes back almost back to normal. Now, we're not seeing a reversal of disease from more advanced forms. When patients reach a certain, I call this a point of no return, we haven't been able to improve them. But we have been stabilizing patients even in a much more advanced forms of the disease. The first case I showed you, the case of Phil, my first patient who I've worked with using this rough approach, has stabilized despite being on hospice for 10 years. So it's possible to arrest the disease in almost every stage, but the improvement, in my opinion, still requires a relatively early intervention. So it is essential that programs like this begin as early as possible. I think the biomarkers are dramatically changing what we're dealing with. We're now able to identify patients even before they present with a substantial cognitive impairment. And also this company, Boston Cognitive, has developed an online random tool called BOCA, Boston Cognitive Assessment Tool, which in contrast to MoCA allows us to, in essence, do a frequent cognitive tests. MoCA cannot be done more than every 3 months because patients simply going to memorize it and, in essence, create a false negative result. Boston Cognitive Assessment is random each time, so patients cannot memorize them. So using the biomarkers, using this new early cognitive screening, we should be able to pick up patients even before they begin aggressively decline. And in this early phase, I think our results in the future is going to be a lot better. So in conclusion, I think we now have programs that allow patients to literally reverse some of the symptoms of Alzheimer's. Programs are still very complex, costly, and logistically difficult. But of course, just like anything else in medicine, over time, things will get standardized. I do think that this is where AI is going to show a quite profound shift in how we practice over the next few years. And I'm going to stop at this. And I think the questions are going to be after I
At the
understand.
end of the session. Thank you, Dr. Kogan, for this insightful and inspiring presentation. We will now continue with our next presenter. Our next speaker is Dr. Alia Al-Aqli, Assistant Professor of Neurology in Department of Clinical Neuroscience at the College of Medicine, King Faisal University. Today she will be presenting her lecture titled Dementia Today, Emerging Trends and Epidemiology and Evolving Therapeutic Strategies. Please join me in welcoming Dr. Alia Al-Aqli. Dr. Alia, the mic is off.
Sorry for that. Okay, so Assalamu alaikum. Good afternoon, everyone. First of all, I'd like to thank the organizing committee of the Saudi Geriatric Society and the Geriatric Conference for their invitation and for giving me this advantage of presenting this talk of emerging trends in epidemiology and evolving therapeutic strategies. So it's all about dementia today. Sorry. Okay, so I have no disclosures. These are my objectives. I'm going to talk about the global epidemiology of dementia globally and in the MENA region. I'll have some overview about the new diagnostics of Alzheimer's disease and overview about the new phase of anti-amyloid therapy and future directives of non-neurodegenerative disorder. So the global prevalence of dementia, given the projected trends in population aging and growth, the global dementia trends to be projected to be increased from 2019 to 2050. It's projected to be escalated from 57.4 million to 152.8 million and approximately 10 million new cases of dementia diagnosed each year. So from this world map, we can see that there is regional differences exist and they are significant with the largest increase in the North Africa and Middle East, almost plus 367%, with the smallest increase usually seen in Asia Pacific and Western Europe. And from this chart, we see also that there's the number of people diagnosed with dementia is higher in the low to middle income countries compared to the high income countries. From a gender perspective, we see also gender differences that female are higher, having the higher prevalence of dementia compared to the males, and it's increasing with the aging and doubling every 5 years. From as we can see from this chart, it's increasing from 2019 and projected to be increased in 2050. And the cause of this changes and heterogeneity and the dementia prevalence is usually related to changing in the population aging growth and also certain risk factor. So as Dr. Kogan mentioned that according to the Lancet Commission of Dementia, there has been update over the risk factors of dementia that usually 45% of global dementia cases can be prevented or delayed by addressing these modifiable risk factors. I'm not going just to go through over them because Dr. Kogan already mentioned them, and thank you to him. So regarding the MENA countries, so as I mentioned before, the cases are expected to be increased by 367% by 2050, and it's rapidly increased by aging. So patients who are aged more than 80, it's estimated to be the prevalence between 13.5 to 18.5%, and also patient aged in the 50s, so their prevalence will be between 1.1 to 2.3%. Also, we see the same gender differences that female are higher prevalent to have dementia compared to the males. So dementia is a growing public burden and it impacts patients, family, healthcare system, and economics. So the projected to be costing dementia will be by 2050 is almost 57.9 billion in 2050. So the main drivers of this rising in the dementia in the MENA region is the variation in the risk factor. We see some risk factor are higher prevalent compared to the worldwide dementia causes. So these risk factors are prevalence of hypertension, obesity, lack of physical activity, and they are intersecting with each other and also affecting the other comorbidities in bidirectional and multidirectional ways. So dementia overview, as we know it all, it's an umbrella term that refers to a decline in cognitive function with impairment in the activity of daily living. It's caused by various neuropathological process. As we know, the most common cause of dementia is Alzheimer's disease, which represent almost 60 to 80% of dementia cases. But I'd like to note that dementia is not equal to disease. So the future advantage in the biomarkers and treatment option, they are focusing on the biological definition of Alzheimer's disease. So they are targeting the pathology. As we know, in Alzheimer's disease, it's usually caused by the accumulation of A beta extracellularly with the neurofibrillary tangles intracellularly. So the second most common cause of dementia, which is the vascular dementia, it represents almost 5 to 10%, and followed by Lewy body dementia. So Alzheimer, it's globally estimated to affect more than 50 million individuals suffer from Alzheimer's disease, and this number expected to be increased to 75 million by 2030. And the prevalence of Alzheimer's disease in Saudi Arabia is approximately 5%, and it accounts for almost 51% of all dementia cases in the kingdom. According to WHO, it's the 7th leading cause of death in 2020 globally. So as I mentioned regarding the pathophysiology of Alzheimer, we know that started by the accumulation of amyloid beta intracellularly, which correlate with the amyloid beta biomarkers, A beta biofluid and amyloid PET, and also followed with the accumulation of phosphorylated tau, which can be measured by the biomarker of P217 and also other phosphorylated tau biomarkers, and also with the tau PET. We see also that following the degeneration and the ongoing neurodegeneration process, some atrophic changes will be seen by in the MRI and imaging techniques, which are or modalities such as the FDG PET. It can be regional atrophy or a regional hypometabolism, and later on the cognitive decline will be appear. So this process will take approximately 10 to 20 years before the clinical symptoms will appear to the patient. Okay, so regarding the Alzheimer Association, according to that, they have modified and revised the criteria for staging and diagnosing of Alzheimer's disease. It depends on the core 1 and core 2. So core 1 biomarker, it will be positive if we have abnormality in the amyloid PET by imaging modality or by A beta phosphorylated tau during the CSF. We see that also the plasma biomarker, it's included in the core 1 category. However, it needs to be interpreted within the clinical context, as false positive results can be seen in patients who have CKD or chronic kidney disease in general. Regarding the second criteria, which is the core biomarker 2, it can lead us to or give us an information about the prognostication and the advancement in the staging process. So we can relate that to the abnormality on the tau PET and also the MTB are tau 243. So accordingly, as we know that Alzheimer's disease exists on a continuum. So we have different stages of Alzheimer's disease, as we have a continuum of the clinical syndrome from stage 0 to stage 6. Stage 0, where we have only the genetic or the genes will be a mutation and abnormal, such as in proserpine 1 and 2 or IPP, whereas the patient will be asymptomatic and his biomarker will be in the normal range. Stage 1, we will have only the a biomarker will be positive, however the patient will be asymptomatic too. Stage 2, the patient will have a subjective cognitive impairment, and stage 3, it's correlating with the MCI, and stage 4 to 6, it's with the dementia from mild to severe. So how Alzheimer's disease is currently diagnosed? It's diagnosed upon a combination of neurological examination, general physical examination, cognitive testing, and biomarkers with the inclusion of imaging and biofluids. So management of Alzheimer, it needs, it's a state of art. We need to modify the risk factors, treating the Alzheimer in non-pharmacological ways, such as cognitive stimulation, physical activity, sleep hygiene, and then pharmacological approach and pharmaceutical and multidisciplinary approach. So regarding the pharmaceutical, as we know that we have the new advancement of disease-modifying therapy, which are the lecanemab and donanemab, and recently it has been approved in Saudi Arabia, only the lecanemab. We are still waiting for the donanemab approval. Both share different mechanism of action. Lecanemab, it's directed on the insoluble form of the protofibril, which affect the downstream of the amyloid pathway, whereas in donanemab, it's affecting the soluble form of amyloid plaques. And to test the efficacy of the lecanemab and safety of it, Clarity study has shown that lecanemab is given to a patient in the MCI range or mild dementia after confirmation of the amyloid pathology. And it showed that 27%, as we can see in this diagram, slowing in the clinical decline on the CDR sum of boxes. Also, the amyloid burden is reduced significantly with the lecanemab, and on the extended period, we see that benefit of lecanemab is extended even more than the duration of the study. However, we have some adverse effects that we usually keep in our mind when we are dealing with the disease-modifying therapy, which are the infusion rate reaction. It's noted to have to be present in 26.4%, and also the ARIA, which is amyloid related imaging abnormality. We have two flavors of ARIA, which are we usually follow with the frequent MRIs, which are the ARIA E, which denote to the effusion and edema, or ARIA H, which is related to the microhemorrhages, intracerebral hemorrhages, or superficial cirrhosis. And the risk of ARIA is getting higher when the patient is having the ApoE4 genotype homozygous. So regarding the eligibility criteria of lecanemab, so lecanemab can be introduced to a patient who have confirmed Alzheimer pathology either by amyloid PET scan or CSF biomarker, and the patient needs to be in the mild cognitive impairment or mild dementia, so meaning in the stage of 4 to 5 with the new clinical staging, and we need to do the ApoE4 genotype for all patients before we start in the medication, because if the patient is homozygous, the patient should be excluded from getting the medication. The contraindication, we follow the MRI just to see if there is any evidence of more than 4 microhemorrhages, history of TIAs or strokes, history of immunological disease, or bleeding disorder in general. So lecanemab can be given IV infusion every other weeks in a dose of 10 milligram per kg. Before we proceed with the lecanemab, we need to have an initial MRI screening within the first 6 to 1 year before the first dose. And then we need to have an MRI done before the 5th infusion, 7th infusion, 14th infusion. So following that, the patient needs to be on a maintenance dose, and this maintenance dose can be subcutaneous or even IV infusion. However, with the dosing regimen can be changed. So why we do the imaging? Just to follow the ARIA, and this ARIA can be staged depending on its severity and the site and the location, from mild, moderate, and severe. And we treat that if the patient is becoming symptomatic. However, we keep the patient on the lecanemab if he is in asymptomatic stage in the milder ARIA form. So the symptoms can be presenting with any focal neurological deficit, history of blurred vision, confusion, even mimicking a stroke. This is why we need to keep in mind that the patient who will be in lecanemab, they should not be on anticoagulation, and they should not receive any intravenous thrombolysis. So the second disease-modifying therapy, which is the donanemab, has been approved its efficacy and safety based on the Trailblazer-ALZ study, where they stratify patients upon their tau level from low to intermediate to high level, and showed that it slowed the progression of the clinical disease in 36% in low to medium tau. However, it's reducing less in 28% in combined population. So that giving you an idea that you need to give the medication as early as possible before the tau will accumulate more and more. And also, the evidence of ARIA here is more. However, with the modified titration, it's becoming less and also almost comparable to the lecanemab. So the risk of progression is to more severe stages with donanemab is lesser in 37.4%. So we are still at the beginning. More therapies are developing in the field that target different mechanism of action in Alzheimer's disease. We have therapies that can target the tau, neurotransmitters, and other mechanisms. So I know it's really difficult to cover all the neurodegenerative disorder treatment. However, there has been an advantage over the non-Alzheimer's disease and neurodegenerative entity over the biomarker. So we can see that, for example, in frontotemporal lobar degeneration, we have a patient who have C9 mutation. We have certain regional atrophy in the MRI. So the MRI considered to be a biomarker for these patients. Also, NFL tend to be deviated 15 years before the symptoms in case of GRN or progranulin mutation. So these biomarkers can help and support the clinical diagnosis and it's used in the clinical research so far. Also regarding the Parkinson's disease dementia, we have the innovation of alpha-synucleinopathy, which can be detected in the skin biopsy and biofluids. Regarding the vascular dementia, so far the best biomarker is the MRI, and inflammatory biomarkers are seen also to be elevated in these kinds of patients. Regarding the treatment option for the frontotemporal lobar degeneration, so far we have the symptomatic pharmacological, non-pharmacological therapies. However, active trials and future directives toward the genetic mutation, the autosomal dominant FTD targeted approach, tau targeted approach, and neuroinflammation are still ongoing. Regarding the vascular dementia, there was a study which was showing that intense blood control can improve the cognitive decline. However, it should be started from early on as the improvement can be seen 6 to 7 years later. So intense blood control early on can reduce the further decline in the cognition these kinds of individuals. So dementia carries a substantial global and economic burden. We are entering a new era of hope in Alzheimer's disease and other non-Alzheimer's disease and neurocognitive disorders in diagnostic and treatments. Precision, personalized medicine approach are expected to improve the outcome and reduce the treatment risk. So thank you.
Thank you, Dr. Alia, for the excellent presentation, and I'm very sure there will be a lot of questions to discuss the matter. Okay, so I'm going to take this also opportunity to introduce Dr. Firas Al-Awad. Dr. Firas is Associate Professor in Psychiatry at the College of Medicine in Al-Imam Abdurrahman bin Faisal University in Saudi Arabia. And yeah, the virtual floor is yours, Doctor.
السلام عليكم ورحمة الله وبركاته.
والسلام ورحمة الله وبركاته.
السلام عليكم ورحمة الله وبركاته. هل الصوت والصورة واضحين؟
Yes. The presentation, and we can hear you clearly. Thank you.
Okay. Well, thank you for the organizing committee for, first of all, inviting me to present this lecture, and I remember their kindness and follow up, and they tried to make things really organized, and they were very helpful. So really thank you all for this opportunity. So my lecture is about managing behavioral and psychological symptoms of dementia, which is abbreviated as BPSD. All right. So they are a combination of behavioral or psychological symptoms that can be called also as neuropsychiatric symptoms. Actually, we call it neuropsychiatric symptoms, maybe in PSD. It includes any disturbance, any psychiatric symptom, regardless of being anxiety or fluid mood symptom, can include anxiety symptoms, sleep. That's all considered as neuropsychiatric symptoms. So when I use the term neuropsychiatric symptoms, it's the same as BPSD. Okay. So regarding about the impact of the neuropsychiatric symptoms, the impact of neuropsychiatric symptoms on caregiver is one of the key things. Uh, Caregivers will have more stress and more caregiver burden when a patient have neuropsychiatric symptoms. The burden from that is much more higher than the burden of the cognitive part or the forgetfulness or the need for assisting them to function in their daily activities. Neuropsychiatric symptoms, unfortunately, also increases the risk of hospitalization in psychiatric wards. Neuropsychiatric symptoms, there are some studies that have shown it cause more rapid functional decline. Also, it can lead to higher economic costs and increase in risk of mortality. معلش أنا ما أعرف هل الصوت مش واضح ولا إيش؟ إذا بس أحد ممكن يقول لي لأني
الصوت
في
واضح
ناس قاعد.
دكتور.
أنا بالنسبة لي الصوت واضح يا دكتور.
طيب أوكي. So in this graph, we can see in almost 90% of patients, at some point of their time, they will have some neuropsychiatric symptoms. This graph shows what are the commonest neuropsychiatric symptoms that we can see in dementia. The commonest is actually apathy. And with apathy, it's commonly misdiagnosed as depression. In my practice, often I get patients after being treated by other psychiatrists. They are diagnosed with depression and they're not responding to medications with antidepressants. But the actual reason of not response to medications because they actually don't have depression. It's about apathy. Depression would be a second commonest neuropsychiatric symptom. Aggression, anxiety, sleep disorders. Uh, It can happen up to 40 order than irritability. Other symptoms which come like at lesser extent are appetite changes, particularly reduction in appetite. Also some aberrant motor behavioral like repetition of motor of movements. Sometimes they like try to like do the same movements over and over. Okay. I don't know. My video is being disabled. Okay, so when we talk about agitation, agitation is one of the commonest causes of referral to psychiatric wards, and is actually, something that you often see in your practice when you treat patients with dementia. It is one of the top reasons where patients present agitation, also psychosis, also sleep disturbances. So what agitation means? The agitation is like a broad term. It can include several behavioral or several symptoms. It can include also repetitive questioning, repetitive asking, demanding, arguing. It can escalate to be also screaming. It can escalate to be resistance to care. And resistance to care is considered part of agitation. So the patient is not allowing the caregiver to provide the care in terms of like hygiene or in terms of feeding or any type of need that the patient needs. It can happen at any stage in dementia, but it often happens more with in moderate to severe dementia, but it can happen in mild stages as well. We cannot really know the reason of agitation, but it can range from fear to because of fear, because of pain, because of overstimulation. Sometimes when they are bored, sometimes when they feel scared, sometimes when they are not sleeping well, or being in a place that's unfamiliar. Some families they try to move the patient from one home to another home, and that can causes very uncomfortable feelings. They need to be in a stable place with a stable environment. They need to be even in the same room, same house. The arrangement of the furniture to be also like in its similar or its usual place. So that familiarity to the place is really important for the stability. And if it's not there, it might trigger agitation and anxiety as well. Also, one of the most commonest reasons where patients present to our clinic, and they might include delusions or hallucinations. So, commonest types of delusions are usually persecutory delusions, where they feel they are being harmed, or they will be they are being followed by someone, and many times that delusion of persecution is often targeted toward the primary caregiver or the person who is mostly involved in caring of this patient. And this is where, primary caregivers might feel like disappointed because they're doing the hard work. They're trying their best, but they are getting, the agitation and the persecutory ideas against the primary caregiver. So we have to teach the family and tell them, delusions are common, and it is common to be seen in primary caregivers more than the patients or the family who are kind of more distant or less involved in the care. It can include hallucinations. Hallucinations are usually visual hallucinations more than auditory hallucinations. Regarding also the distress, so management differs different on the level of the distress that can cause to the patient or the family. الصوت واضح because I get some comments on the chat إن صوتي قطع.
Oh no, the voice is clear, doctor. You're good.
نعم دكتور كويس الصوت؟
Yeah, we can hear you, doctor.
طيب. Sleep disturbances. We have too many neuropsychiatric symptoms. It would be difficult to cover all of them in one lecture. So I try to focus on three commonest presentations, which are agitation, psychosis, and sleep disturbances. But there are other symptoms like depression, anxiety, etc. So sleep disturbances can be insomnia, which is difficulty falling to sleep. Sometimes it's fragmented sleep, so they don't stay sleep. They don't sleep still. Sometimes they wander at night. They try to move around, knock the doors of families, and sometimes they have reversal of sleep cycles. So they sleep during the daytime instead of the nighttime. So all of these are common presentations of sleep disturbances. Sleep disturbances really causes distress to the family because it will, the family will not be able to sleep. And families sometimes they have commitments. They have to, sleep, wake up, go to work. And if they're like father or mother, they having trouble in sleep, that might affect the family as well. So that can create a caregiver burden. We have to distinguish between insomnia or reduced sleep with circadian sleep disruption. Because sometimes the family will say the patient is not sleeping. But when you try to dig more, and you will find the patient is actually sleeping and get the daytime, or he's taken too many naps during the daytime. And if you calculate the time of naps, you will find it almost like 6 hours or more. And the average sleeping hours usually between 6 and 8 hours. We have, other reasons for sleep disturbances could be medical also, like nocturia, sleep apnea. But we want to make sure that the family know napping during the day, inactivity, not doing much, not doing any physical movements are reasons for having poor sleep at night. So, reduction of nap, reduction of improving activity can improve nighttime sleep. So why do these symptoms occur? Because of, maybe because of different factors, interaction between the brain disease, unmet needs, physical illnesses, caregiver factors, and environments. The changes that happen in the brain, whether the reason because of vascular or Alzheimer dementia or Lewy body dementia, it will affect many areas in the brain that are involved in emotions, behavior, personality, and impulses and perception. So it is a brain disease, and psychiatric symptoms are caused by brain disease. The role of caregiver and the role of environment is important to be addressed and to be, probed, because sometimes the caregiver has some kind of stress. He's anxious, so that can trigger these symptoms, the agitation or the psychotic symptoms. Sometimes the caregiver is rushing, arguing, unable to have a good positive community, the symptoms of agitation. So we have to support and train caregivers and not blame them. Sometimes the environment they are in is actually not quiet, not comforting environment. Maybe there's a lot of noise, there's poor lighting, or there's a lot of light. Maybe there's overstimulation. These all factors have to be, addressed and asked about. So when we try to assess and treat, we like to use what we call it the DICE approach, DICE. So first we ask the family to describe the symptom. For example, the agitation, how often, how severe, what time, can you see any triggers? If it's about psychotic symptoms, how often it happens? Are they distressing to the patient? Are they distressing to the family? Is it causing any agitation, any aggression? Uh, we need to get as much as information as we need, because that will determine our treatment approach. If we find it to be severe enough, then we might to jump to medications rather than non-pharmacological approach. If they are mild, infrequent, then we prefer to do non-pharmacological approach. We try to investigate the reasons, rule out other causes. Maybe they have some kind of constipation, pain, something medical or organic that can be corrected. We have to create a plan and evaluate and continuously evaluate the need for that treatment. So first step is we do the DICE assessments. We try to treat the modifiable causes. Then we try the non-pharmacological approaches first if it is appropriate. But if the symptoms are not mild, if it's severe enough, we might jump to pharmacological treatment. Or if they are not responding to non-pharmacological treatment, then we might jump to the pharmacological treatment as well. Then we review the medications and from time to time to try to wean them off. Non-pharmacological approaches can include sensory and creative therapy, for example, Quran or music, reminiscence, which is like, reminding them, showing them images, pictures from the, past, so that can create really positive emotions in patients. And taking them to old places that can help the patient to feel more calm and more comfortable. Also, we try to train caregivers about communication. What's the best way to communicate with the patient? How to de-escalate? Give them de-escalation techniques. And we try to educate them about the environment, for example, to make it a quiet place, improve the lighting, try to emphasize a routine, try to emphasize being in one place, being around familiar people. Generally, regarding pharmacological treatments, we only treat symptoms. So it is symptomatic treatment. It is not like if somebody is having psychosis, we are not treating it as schizophrenia. Schizophrenia is a chronic disease where patients need to be on the medication lifelong. But here we try to treat the psychotic symptoms only like symptomatically for a period of time. When the symptoms resolve and the patient is fine, we try to wean them off. We often start with a low dose and go slow. That's a standard approach. And we try to review the need for the medication regularly. We don't keep the medication, the psychiatric medications, infinitely. So it's not forever. So when medication is justified, when the patient display or he exhibits major depression, uh, having like low mood, death wishes, suicide ideation, when there is aggression also, when there is psychosis that is causing harm to the patient or the family, when the family or the patient feeling distressed, the family showing caregiver burden, the patient is showing a lot of negative emotions, a lot of anger, a lot of anxiety. This is a time where we need medications. So what's about the pharmacological treatment of agitation? Antipsychotics, one of the commonest. But there are other medications that can be used to treat agitation. We can use trazodone. We can use SSRIs such as citalopram, mirtazapine. There are a lot of studies showing that it can help with agitation. For me, I usually start with SSRIs if the agitation is mild. And if the agitation is severe or I need fast response, then I would jump to antipsychotics. Benzodiazepine usually to be our last choice because of the dependence and the risk of falls. But I use benzodiazepines, particularly clonazepam, Rivotril, in severe cases. When I try SSRI and it's not working, I try antipsychotic, not working. I try mood stabilizers, even valproic acid, the dipakine can be used. It can be helpful. The NMD antagonists like memantine and the acetylcholinesterase inhibitors, even though there is some evidence showing that it reduces agitation, the evidence is weak, so we don't really recommend them to be used to manage the agitation. So what sort of antidepressants we can use? So as I said, we use antidepressants in mild cases, mild agitation. We can use citalopram, escitalopram, sertraline, mirtazapine. If you want to choose, a medication that, usually cannot go wrong, I will go with sertraline because sertraline does not have any impact on patients with cardiac disease. But escitalopram and citalopram it can cause QTC prolongation. So people with cardiac disease, they might have QTC prolongation. So if you want to choose one, choose sertraline. Start with 25
Dr.
milligrams.
Firas, you have 2 minutes to conclude the
Okay.
presentation. Thank you.
You start with 25, then go to 50 milligram, and then increase the dose accordingly. How about pharmacological treatment of psychosis? So in psychotic symptoms, the antipsychotics usually improve the symptoms modestly. But there are some adverse events, includes falls, sedation, extrapyramidal symptoms, metabolic side effects such as diabetes or hypertension. So we try to not use them unless we really need them. And you know about the black box warning. Black box warning is increased risk of stroke by 2%, increased risk of sudden death, and increased risk of infection. And it's our duty to explain to the family the black box warning. We can use these medications to treat psychosis. Usually we try olanzapine or risperidone or quetiapine. Other medications that can be used, brexpiprazole, aripiprazole, pimavanserin. But the first three are the commonest medications to be used. Regarding doses, we usually try to start with the lowest dose, and we don't really need to go to the highest maximum dose. We usually need, the maintenance dose usually almost like 1/3 the maximum dose, or by most half of the maximum dose. This
Dr.
study,
Firas,
now,
I'm really sorry and hate to interrupt your presentation, but our time have finished for this presentation. So we're probably gonna move into the Q&A. And before we do that, I want to thank all our speakers, either in Saudi or from different parts of the world, of joining us and staying up with us. Thank you again, Dr. Kogan. I see Dr. Rockwood have joined us too. So thank you all for being here. Dr. Afaf?
Yes, we'll start our Q&A session. We have the first question directed to Dr. Kogan. Dr. Kogan, you mentioned that Alzheimer's disease is no longer viewed as a uniformly progressive disorder, but rather as a spectrum with significant variability, individual variability. As we continue to move away from the traditional one-size-fits-all approach in dementia care, which emerging precision medicine you think, or strategy you think or believe hold the greatest promise in the future?
I think the starting with biomarkers in combination with volumetric tests, particularly MRI with NeuroQuant, I think is going to hold the best, because we know that prevention works a lot better than the actual treatment. So if we can figure out precursors to Alzheimer's, what we now call, even before MCI, when SCI starts, even before SCI, we can identify patients at risk. And I think it's going to be a combination of genetics, early identification of genetic risks, and then following in biomarkers and volumetrics combined, so that we can engage the patient in lifestyle optimization way before the symptoms occur. I think once we shift that, and then we gradually start decreasing the risk, as the data progresses, we're also going to identify which methods that I mentioned, the precision tools of actual modifying drivers of disease, are going to be more accurate. Right now, we know that protocols work, but we don't know for whom exactly and why. So I think there's too many unanswered questions, and the research for this is very difficult because you're not applying one treatment, right? And because when you're doing the comprehensive integrative approaches, research gets a lot more sophisticated than the current randomized control trial, simply because you can't randomize when you're using 10, 20, 30 treatments simultaneously.
Thank you, Dr. Kogan. Clear. I'm going to invite the audience to write their questions in the chat box, and we are going to read any question.
I got a question for you, Dr. Kogan, if you allow me. So I want to get your perspective and from your experience in integrating integrative medicine or alternative medicine into the conventional medical practice. How was your experience? Sometimes you see some resistance from some of the medical communities regarding that, but seems like from the evidence you presented, even though briefly, that there's a very promising answers that can come with that.
Yeah, I think the resistance is expected, right? I think the medicine, as we know, is conservative field, and it should stay conservative. If there is no evidence for something, why are we doing this? So I think there is a little bit of a clash of what we would describe not just alternative, but traditional approaches. For example, acupuncture, it took US 20 years before acupuncture is now covered by every insurance. And I think it's going to be similar. As evidence gradually accumulates, certain things going to start being called standard of care rather than integrative or alternative. But it's a very slow process. I think the biggest concern is what I mentioned just before. We know how to do trials against one treatment, but when you're looking at the very comprehensive approaches that involve multiple different modalities at the same time, research gets much more sophisticated. You have to be able to conduct studies that are not looking at one outcome, but they're looking at the composites. And I think the part of it is the science is not even quite there yet to do something like this. My prediction is AI is going to dramatically change this. We will have capacity of synthesizing data fast and accurately.
And looking into neuropsychiatric disorders like agitation, is there anything that is in the pipeline or being published from the alternative medicine perspective that kind of addresses that too? Or is it if we can put this multifaceted approach eventually, and so the neuropsychiatric symptoms should be mitigated?
So actually, we have a tool now that's profoundly effective, and we understand why. The most effective tool is medical cannabis. And the reason is the most significant cause of neurobehavioral changes is actually a drop in endocannabinoid tone. For whatever reason, around 2 or 3 years into Alzheimer's, the molecule called FAAH goes up, and that molecule causes disruption of endocannabinoid tone. So our body stops, it tries to make cannabis, but it can't. It gets broken down fast. So far, the most universally effective tool is actually low-dose THC. Probably in the future, we'll have other tools. There's several molecules in pipeline. One is C15. It's a type of a fatty acid that blocks FAH increase. But we don't know the dosing. With medical cannabis, because it's in US, it's just gotten legalized, and many states have already used it for many decades. We do see this as the most promising and most effective and most universally effective. The prior presentation was excellent. And the problem with all the medications we're using, that they actually have a lot of harm. Benzos, even tranquilizers, and as accurately presented, they all have risk. Low-dose THC seems to be the safest, but protocols have not been exactly worked out.
Okay. Thank you, Doctor.
Thank you.
Dr. Afaf, if you can get some of the questions on the chat. Thank you.
Yeah, Dr. Maysoon, she's saying thanks for the excellent presentation. As disease-modifying therapies for Alzheimer becomes more available now, how do you envision balancing biomarkers-driven treatment eligibility with real-world geriatric factors like frailty?
I think this is to Dr. Alia, right?
Yes, yeah.
Yes.
Okay. So thank you for this great question. I think we should just interpret the biomarkers based on the multimorbidity that the patient is having. So, for example, these biomarkers can be affected, especially with the phosphorylated tau 217, by the comorbidities and the such as CKD. So, we should not rely primarily on the plasma biomarker for now to proceed with disease-modifying therapy. We should the PET amyloid and the CS biomarker can be 400% can be sure that we can proceed with the disease-modifying therapy. So I think that this is in regard to this question.
Dr. Alia, I have a question regarding the same biomarker thing. So, what are the current challenges in utilizing dementia biomarkers and newer therapeutic options in Saudi Arabia, particularly regarding accessibility, patient selections?
Okay, so regarding the biomarkers, they are still not present in all the hospitals in Saudi Arabia. So some hospitals are having the amyloid PET, some of them are having the CSF. So it's kind of fragmented. But I think my colleagues are working on unifying and having an established pathway to have a precise and better approach from the primary healthcare provider to the tertiary physician. So this is in general, I think.
Thank you, Dr. Alia. We have a question for Dr. Firas Al-Awad. Considering the growing aging population, what do you think are the most important priorities for improving BPSD care and support for patients and caregiver in Saudi Arabia?
Yes, that's a really good question. I think family, they really need a lot of education and support, particularly like if there is some kind of like group support group sessions, educational sessions, how to deal with the patients, how to communicate with them, how to de-escalate. That will reduce the neuropsychiatric symptoms quite a lot. If it's not working, then we go with medications, and most often medications are needed for severe agitation, severe insomnia, severe psychotic symptoms. Anything severe, usually we go with medications regardless of regardless the triggers.
Thank you, Dr. Faraz. Anyone of the audience would like to ask a question, please open your mic and you can start asking our presenter, our speaker.
I see a very interesting question from Dr. Sultan Al-Amri here for Dr. Kogan. So, Doctor, would you consider many supplements and herbs as a concern when implementing the integrative protocol? And if yes, how could that be optimized? And I know this question would come from, the reality here in Saudi Arabia. Older adults today scroll on the social media all day, and they have an open access to all different kind of either local or international platforms to get all kind of supplements that they want to see in the social media. So, how would you consider the many supplements and herbs as a concern when implementing the integrativeness protocol?
It's a great question. So I'll divide the answer into two parts. So first part is actually much more concerning, and that is the quality of the products. Unfortunately, it's exactly what you just described. I like to call it wild, wild west of supplements. The controls are lacking. There are a variety of contaminants in many products. Often we've done research where the bottle would say one thing and there would be none of the substance inside. So the quality is a big problem. Because of that, the field unfortunately has a very negative connotation as a whole. But the second part, we do have a higher grade nutraceutical products in the US. We do have distributors that check every bottle that gets sold. In US, the product's called Full Script. This is a kind of a universal dispensary that is pharmaceutical grade. If you're using the supplements appropriately, meaning you understand where there's interaction risks, you understand how to use them, the problems are very minor. Most of these products are relatively safe, or they're much safer than most of the medications we're using. We now have companies that can compound all of the nutrients into one package, dramatically reducing cost and making them into the powder, because a lot of the patients, as they progress, they really have hard time swallowing so many tablets and capsules. So we basically make it once daily smoothie for them as a part of one of their meals. But I agree, it's a very important topic. There's a lot of drug to herb and to supplement interactions. That's what I mentioned. I think the programs that are utilizing these resources have to be very sophisticated. They have to use some basic AI tools to constantly double check and monitor for interactions. I think in the future is bright, partially because these nutrients can be produced at relatively low cost and quickly introduced, and because they can be compounded.
Thank you, Doctor. Dr. Afaf, I think there's a question from Dr. Hassa. So the Dr. Hassa question is, so are the biomarkers still in the developmental stage? We still working on the pathway to make it more available, as my colleague Dr. Alia mentioned. So this is a point of information from her side. Okay, thank you, Dr. Hassa. Yeah, this is a work in progress. Any other questions? Yes, we're still working on that, Dr. Kogan. So there's still, since the system is fragmented, so we have a lot of entities that work as large pockets of healthcare providers, either in the governmental or private sector. But again, this is our duties as the Geriatric Scientific Society, along with our colleagues in the Neurology Saudi Society, to implement that, since a lot of leaders in healthcare are members of the two societies. Okay, is there any other questions?
There is a great question in the chat I'd like to answer if that's okay.
Go ahead,
Yeah,
Doc.
there is a great question here for Dr.
Yeah,
Kogan
so
Yeah.
in standard of care, like when we use medications, we always do one thing at a time, right? Just because we know the toxicity risk for a lot of medications there. In integrative approach, we don't do that. We stack the things immediately one on top of each other. It's not unusual for us, after first initial assessment of tests, biomarkers, and MRI, we would give patients 20 treatments at once. Now, all of them are gonna not involve medications, so we don't have to monitor as much. But it's a really important concept, because if you start stacking things one at a time, it'll take many, many years to get there. If the treatment is purely lifestyle based, I think the monitoring requires even less. Once you start adding supplements, you have to be a little bit more careful, but still, it's a great question. So often when we look at drivers, we don't pick up every driver on a first visit or two. So sometimes we'll start the lifestyle and then work out the drivers over, say, 3 to 6 months. We tell patients it takes about 6 months to get clarity what's driving each person's decline, and then in another 6 months to try to modify all that. So usually the 12 months period is when we'll tell them, by the end of first 12 months, we can predict whether you are going to get better or stabilize, or you're going to continue progressing.
Excellent. Thank you, Doctor.
Thank you.
Okay.
I think we came to a conclusion. You have any question, Dr. Trad?
Yeah, I'm just scrolling on the chat here. Yeah. So, and since the protocols and interventions are individualized, what time frame do we give to each intervention before moving to a different one from Dr. Yazid Al-Jani? I think Dr. Kogan, correct me if I'm mistaken. Yeah, this one was answered by you just now. Okay.
Yeah.
Okay.
All right. I think that will conclude our third session, and we are moving forward to the next session. Thank you so much, Dr. Kogan, Dr. Al-Akli, and Dr. Al-Awad, for the informative, inspiring presentation. Dr. Trad, the floor is yours to introduce the next speaker.
Okay.
Dr. Rad, the mic is off.
Assalamu alaikum wa rahmatullahi wa barakatuh. I think I'll
Alaikum
take it
assalam wa
from
rahmatullahi wa barakatuh.
Dr.
So yeah,
Trad
in
to
our
give
next
you a
session.
break.
No, you're fine. You're fine. So Dr. Sahel Al-Amri is a consultant of internal medicine and geriatric. He's the head of Geriatric Medicine Division and executive board member at the Saudi Geriatric Society in the Kingdom of Saudi Arabia. Dr. Sultan, the floor is yours. Thank you.
Thank you, Dr. Trad. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi, everyone. Good afternoon. I'm happy to moderate this session, the fourth session, which is titled as Caring for Older Adults with Complex Needs. I'm happy to introduce our next presenter, who's Dr. Ali Al-Amir. He's a consultant in geriatric medicine and family medicine with a great training background from Karolinska University in Sweden. He works in the College of Medicine, University of Dammam in Saudi Arabia. The topic will talk about clinical management of complex older adults at long-term care, focus on wound care. As Dr. Ali Al-Amir also has an extensive experience directing and providing services in rehabilitation center in eastern part of our country. So the floor is yours, Dr. Ali. Dr. Ali, make sure your mic is unmuted.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you for your kind invitation. And it's an honor to be with you here today virtually. And I hope next year we will be together and meet you all. I'll go through clinical management of complex older adult at long-term care, focusing on wound care management. My name is Ali Al-Amir, geriatric medicine consultant, chief of LTC in Al Musa Rehabilitation Hospital. I'll go through recognized of pressure injury as geriatric syndrome, comprehensive geriatric assessment rule, and broaden scale risk assessment, and how could we do proper diagnosing and staging, evidence-based prevention bundle, and how and when to escalate, and multidisciplinary team role. Why pressure injury matters in LTC? Because it's not only a skin problem, it's a marker for frailty, immobility, malnutrition, and even cognitive decline. And here we need to understand it's a serious complication, which include pain, infection, sepsis, increased length of hospitalization, and increased mortality. So to have a pressure injury and to do a wound care referral, it's not enough. So we need to have a comprehensive plan. So pressure injury, it's a marker or aspirate for a systemic factor beneath. The first step, if we have a wound issue or pressure injury, we need to make sure from our diagnostic, is it a pressure injury or is it moisture-associated skin damage, incontinence, dermatitis, ischemic venous ulcer, or skin tear? So before we go to staging and to do a referral or to take a lab, we need to make sure about our diagnosing. And we need to document the presence of injury with the admission or facility acquired. And we need to, because each different wound has different management. For example, if it's moisture associated skin damage, we need to improve the incontinence issue before we start pressure offloading. So, or if it's a vascular issue, we need to have a vascular assessment, not just focusing about comprehensive wound management. And then we need to classify and to identify a risk factor for our patient. First, we have mobility and function risk factor, which is bed-bound, chair-bound, cannot repositioning independently, post-stroke patient, contraction, advanced dementia, and reduced sensation. On the other hand, we have systemic factors like incontinence, big tube feeding, weight loss, diabetes, and chronic kidney disease, which affect the perfusion, immunosuppressive medication, and palliative care patient. So these risk factors we need to be identified to have a realistic plan of care. Then we go to the assessment. One of the tools which is well studied and tested a lot in LTC, it's a broadened scale. We need to do it with the admission and within 24 hours of admission. And broadened scale include sensory, moisture, activity, mobility, nutrition, and friction. So any score 18 or less in broadened scale, it means increased risk to develop pressure ulcer. So we need to have a prevention plan. And a lot of literature review and study, it showed that the first 4 weeks here is the highest risk to develop pressure ulcer. So we need to do our assessment for broadened scale with the admission within 24 hours, then weekly for 4 weeks, then monthly, then quarterly. Then we need to repeat it anytime there is any change in the clinical condition of the patient, not only if the patient developed pressure ulcer. So even if the patient developed acute kidney injury or transferred to ICU, so I need to start my reassessment again. Then we need to do a full wound assessment. Here, the most 2 points to be done, that documentation and to be standardized, okay? So we need to have a standard tools like we have a location, stage, size of this wound, a wound bed, is it granulation, necrosis, what about exudate, amount and type, and then I need to see if there is tunneling or undermining. Also, I need to take care and evaluate the pre-wound skin, pain assessment, any sign of infection, is it even we mean local and systemic, and we will come to it. So weekly wound measurement and the standard of tracking, this is a very important point to have a standardized weekly assessment of the wound. Now we will go for staging. Stage 1, here for pressure injury, the intact skin, and it's non-blanching redness. So it means you will find a red area. If you press on it, the redness will not disappear. It will be continue to be red. So in dark skin, discoloration, warmth, it would be, we could notice this area. The most important here point is not about the dressing. The most important point here is immediate offloading and repositioning with skin protection. For stage 2, it's partial thickness, dermis exposed, shallow wound or blister filled with fluid. So we need to protect from to develop pressure ulcer by repositioning and moist healing environment. When it comes to stage 3, here full thickness, fat visible, but we cannot see any bone or tendon. So structure wound plan here we need to have, and we start to think to refer the patient to wound team with maybe nurse with expert in wound management. Stage 4, here we have a full thickness and we could see bone, tendon exposed, and this is a high risk wound. We need to involve physician, wound team, maybe we could consider the imaging like X-ray or MRI, and sometime we need to involve surgery. Special categories for wound, it's unstageable pressure ulcer, which based covered by slough or eschar, depth unknown, you cannot see the depth. Here, most likely we need to do debridement, but not for all unstageable. So if you have a dry heel eschar, you do not remove it unless if there is a sign of infection, there is any discharge, we think about debridement. Otherwise, we keep it because it works as a biological covers. For deep tissue injury, here the skin is intact, but the injury is below the skin. We could find deep red, purple discoloration, and here the most important with deep tissue, deep tissue injury, it's rapidly deteriorates. So we need to have a tight observation and close monitoring for the wound team. Infection assessment, we focus about the patient overall. There is systemic sign, fever, tachycardia, hypotension, or it could be local, like increased pain, redness, increased discharge, especially after cleaning. So, or we could finding new necrosis or tunneling, or maybe we could find, especially in older adults, sometimes they don't have any fever, any tachycardia, only new delirium. So we need to think maybe this is a sign of systemic infection, sign of a pressure injury, lab like rising of CRP and white blood cell. The most important, colonization is common. So do not start every time antibiotic only for colonization. So antibiotic need to be started only if you have a clear infection sign or local. And the most important, you need to go with the guideline, especially local antibiotic guideline in your facility. In Al Musa Rehabilitation Hospital, long-term care, we have an antibiotic guideline which is updated every year. We would be very happy to share it with you, and it will be guided you through which the proper antibiotic to be used. And the most important in your patient to go back and review the previous culture when would you start antibiotic to avoid antibiotic resistant or C. diff or other complication of overusing of antibiotic. Osteomyelitis risk, especially when it comes to stage 4, over bony prominence. If you see a bone in a wound, you need to think about osteomyelitis, deep tunneling, a persistent discharge, even with all the intervention, unhealed pressure injury, you need to think about osteomyelitis. So high inflammatory marker in the lab also increase our suspicion of osteomyelitis. One practical test is a prop to bone test. So it's a bedside, you just have a sterile items and you go to the deepest point in the wound. And if you feel a hard surface, so it's a positive test and it increases the risk of osteomyelitis, and you need to think to do imaging, X-ray or MRI. X-ray, it's easy accessible, but the point with it is you will not diagnose or catch an early stage of osteomyelitis. MRI could help us to diagnose early stage osteomyelitis. So if you have a suspicion of osteomyelitis, it's really important to involve a wound and surgical team. Nutrition and hydration is a very important and fundamental cornerstone in pressure injury treatment. So you need to have a weight measurement to evaluate the trend. You need to act rapidly if you notice any weight loss in a patient with a pressure injury. If a patient tolerate oral intake, to have a nursing feedback, it's not enough to say, oh, patient ate well or less than normal. You have to be a specific percentage, like half of a breakfast or more, less than the half. So we need to be specific when it comes to oral intake. Protein intake play a major role. So clinical dietitian calculate what's the needed protein for each patient according to the weight. Micronutrients like vitamin C and zinc, very important. So stage 2 and more, you need to refer to dietitian, or if you notice any poor oral intake or malnourished or non-healing pressure ulcer, review your plan and your diet program. A wound cannot heal in a malnourished patient. Other very important point in LTC, albumin to be measured from the blood test, it's not a reasonable marker, especially when it's in acute phase or there's infection. So albumin will be for sure low, and it will not reflect the nutrition status for the patient. Perfusion and pain play a major role also in the pressure injury. So we need to assist for peripheral artery disease. We need to check for capillary refill, poor pulse, review chronic disease which affect the perfusion and could affect the healing for pressure injury. Diabetes, chronic kidney disease, heart failure when it causes edema, and edema affect the healing of the pressure injury. Ischemia suspect, you need to have vascular assessment first before you do a comprehensive dressing, because if you do repositioning and the proper dressing for ischemic suspected wound without vascular assessment, there will be no improvement. So vascular assessment is the cornerstone. For pain, even with patient with dementia or cognitive decline, or a patient with brain injury, you will not have a feedback about pain, but you need to be following the face, any tachycardia while changing the dressing. It could give us information about pain, so we need to give pain medication before dressing change. Prevention bundle, this is the most important point in the management of pressure injury. Daily skin inspection, repositioning Q2 hours, pressure relief mattress, heel offloading, moisture and incontinence management, nutrition and hydration optimization, avoid friction share during transfer, proper lifting technique, wheelchair coaching assessment, and no prolonged sitting without relief. Avoid donut cushion because it increases the pressure on the surrounding area, manage of contracture and maintain mobility, and family caregiver education is an important point also. For repositioning plan for bed-bound patients, so Q2 hours, 30-degree lateral tilt lift, and avoid the 90-degree to avoid the pressure and major trochanter, float heel of bed and below for bony prominence. What about chair-bound patients? So here, repositioning Q1 hour if unable to shift, limit sitting if sacral wound, assess wheelchair fit and position. Moisture and incontinence. So as you know, incontinence major skin breakdown contributor. We need to, if patient was able to walk, so toileting is casual, and Q2 hour incontinence care with the cream and diaper care. Treat diarrhea early. Differentiate pressure injury from incontinence dermatitis, as we mentioned before, because with incontinence, repositioning, it's really important. But if you don't solve the incontinence problem, there will be no improvement with the management plan. Catheter only if medically justified. It's not only for nursing convince or you just family, if the family asks for Foley's catheter. No, it's if medically justified, we use the Foley's catheter. Dressing and selection. Here, we need to think about what is the best for the wound, not what we have in our hospital or what we usually do. So we need to choose according to the wound. So if it's low exudate, moisture like hydrogel would be good. Moderate heavy exudate, Arignate dressing. If we notice any tunneling or deep wound, so light packing, and avoid overpacking because it causes more pressure on the pressure ulcer. Contamination risk, so we need to have waterproof dressing. And the principle is to maintain moist environment because moist wound heal faster than dry wound. And we need to protect the pre-wound area and to avoid maceration. Minimize the dressing change. And this is an issue, especially with the family in LTC. Sometimes they think frequent dressing change, it would be better for the patient, but it's not true. So we need to minimize the dressing changing if it's to avoid the trauma and keep time for healing for the wound. Debridement and antibiotic. For debridement, there is different option autolytic from the body itself, enzymatic. We use sometimes mechanical as sharp and surgical. Do not debride stable dry heel eschar, as we said, unless if we notice any discharge or infection sign. For antibiotic, as we said, do not treat colonized wound, only if you notice any sign of infection locally or systemized, so you start antibiotic. Because as you know, overusing of antibiotic, it could increase the risk of resistant renal function affection and C. diff risk. When to investigate? So, labs as CBC, hemoglobin level, renal function, diabetes, CRB, it's really important, but we don't do it for all pressure ulcer. We do it if we have any stage 3 and 4, unstageable wound, discharge from wound, fever, patient with delirium, hypotension suddenly with the patient with the pressure injury, immunocompromised patient. So we take these lab. And also important to have urgent escalation if we notice any sepsis sign, cellulitis, exposed bone, or systemic infection sign. And any delay in escalation in these scenario can be increasing the mortality rate. Also, to be realistic, when it comes to LTC, bed-bound patient, advanced dementia, we need to think about sometime we are facing unavoidable pressure injury. So not all pressure injury are avoidable, even if we do all these nice preventable bundle items, especially with severe frailty, advanced dementia, poor perfusion, end-of-life care, hemodynamically unstable patient on vasopressor, repeated or refuse of repositioning. So, but before we say it, this is unavoidable pressure injury, we need to do proper documentation. We need to have our risk assessment, prevention, implement bundle, a plan. Our plan need to be revised frequently. We need to review the nutrition plan. Is the patient receiving enough amount of protein and micronutrient? Also, we need to involve all the team feedback about our management plan. Maybe we are missing some points. Also, goal of care discussed with the family and explained to them. Multidisciplinary team approach in LTC, it's not only a lovely word that we use or just emotional things. It's really a fundamental and a very important point. It's not a one-man show. Physician need to involve in diagnosing and staging, nursing and daily assessment, and to escalate when it need. Wound care nurse to decide which type of dressing are we going to use. Dietitian to review a nutrition plan of care. Pharmacist to choose the proper antibiotic if needed and to review the anticoagulation need. PT, OT positioning, social worker to inform and explain to the family goal of care. Administration to see any missing equipment or any supply mission, and to supervise our KPI and how are we doing in our management. So interacting geriatric syndrome, so pressure injury are not isolated item, or so they interacting syndrome with others. I'll not go through all, but hypertension medication or over treatment with older adult could cause orthostatic hypotension, which lead to falls, immobility, and cause a pressure injury. Other example, heart failure patient with edema, immobility, and then increase skin breakdown. So as you see, it's a interacting syndrome. We cannot treat only one thing. So at the end, this is when it comes to LTC model, we need to have early recognition and all the team aware about this. Structure monitoring, standardize the most important things. Medication review, nutrition and hydration review, skin wound prevention bundle, avoidance of over treatment. Sometimes to do less is better in management plan. Clear escalation criteria, and all need to be aware of it. Care planning, and we need to involve family. Documentation of risk, it's a very important point also. Thank you very much, and I'll be happy to if you have any question.
Thank you so much, Dr. Ali. Inshallah, we'll keep the questions to the end of this session. It gives me a great pleasure to present or to introduce our next presenter, Dr. Walid Al-Karaidi. He's a consultant and assistant professor of internal medicine, geriatric medicine at King Saud University. He's a general director of home health care at the Ministry of Health in Saudi Arabia. I will take this moment also to congratulate him on his journey and efforts that he have devoted at the Ministry of Health, as he's going back to the university now as a full-time doctor and professor. So Dr. Walid will talk about the home health care experience and system in Saudi Arabia, the current landscape and future directions. Dr. Walid, تفضل.
Thank you so much, and it gives me a great honor and pleasure to be standing before you here today. And also, I'm really honored to be standing shoulder to shoulder with Dr. Prof. Ken. Shout out to Ken from Vancouver, Canada. I hope you are enjoying the conference. And so I'll try to make my presentation brief. Please, Dr. Suhail, I want you to interrupt and interject at any point and remind me. Maybe you can always remind me to stop at 2 minutes, so I don't go beyond time. So, are you going to share the slides from your side, or shall I share it from my side?
Try
Yes,
from your
Dr.
side,
Walid.
Doctor, and then if
Okay.
there's a problem, we can do it.
Okay, no problem. Just a second. Okay, and here we go. Can you please, you can see my screen?
Yes, we
Yes,
can
Dr.
see the screen now. Just go to the presentation mode and
Yeah, it's actually in the presentation mode now, so.
yeah, that's it. We see it now.
Okay, good. So I'll be talking today. I will try to link the home health care initiatives and programs that we have developed so far with the Saudi initiative towards age-friendly healthcare system. So the objective of this presentation is to understand the demographic and the health transition in Saudi Arabia, recognize the strategic national vision and system enablers supporting the healthy aging and defining healthy aging and how it aligns with the Vision 2030, explore the national programs and innovation, also talk about the global evidence and WHO framework such as Healthy Cities, ICOP, and age-friendly health systems, and how is the our efforts and our programs here locally to implement these and try to identify measurable outcomes and lesson learned from the building such a sustainable system integrated with other models of care. So, as you know, the number of older adults will nearly double by 2030 in Saudi Arabia, and that's something actually due to the multiple efforts and initiatives that has been invested in the kingdom in multiple areas, specifically in areas related to social health, medical innovation and programs, We've heard a lot about the vaccination, and we've heard also about the NCD programs that have really helped a lot in reducing the child morbidity mortality. Therefore, we've seen the impact and the fruit of this by witnessing in a very short time the improvement in life expectancy. But Saudi is still a young country, as we know, although we are the population in Saudi by 2024 is around 35 million. Same thing in 2026, reaching almost that number. Only 1.7 million people are above the age of 60. So that's comes down to 4.8% of the total population, and it's only 2.8%. We only have 2.8%, and just above 1 million are above the age of 65. However, by year 2023, we are seeing that this number is rising fast, and perhaps this will represent a significant proportion of the population. So how are we doing from workforce perspective? So in Saudi, actually, just 5 years ago, when I was doing looking into the workforce and the expert geriatricians in Saudi, we were talking about having 30 to 45 geriatrician in Saudi Arabia, and we were almost panicking looking at these numbers because that represents a significant shortage to the existing services. And if we apply this to the projected numbers that we just talked about, then this will create a significant workforce shortage. Just that's only talking about the geriatric doctors. We're not even talking about allied healthcare such as nurses, specialized allied health services, and so on. However, working in a coordinated, multidisciplinary effort within the ministry and working with other entities, so multi-sectoral approach, we were able to actually put a national target towards increasing the geriatric workforce, and through introduction of one regulatory measure, which is having a mandatory and obligatory specialized geriatric physicians within long-term care. That, and with the growth and investment in the long-term care service in Saudi, we've seen the significant rise in geriatrician. And in 4 years, the number of geriatric workforce have increased sharply to almost above 80 doctors. And that put us in the top ranking countries compared to the other G20 countries. And now we have around 9.3 geriatrician to every, for example, if you compare it to per 100,000 elderly adults. And this is a great metric to track, and this can help us as policymakers, as Saudi Commission for Health Specialists, maybe the Ministry of Human Resources, and all these entities looking into increasing the capacity for geriatric service, into designing programs addressing this national target, which is a very responsive metric that can definitely have a downstream effect on the quality of care that come as a result of such efforts or program. And so other than introducing a regulatory measure, we also worked with the Saudi Geriatric Society, worked with the Saudi Commission for Health specialists to spread to first initiate the first fellowship program in Saudi, and that was a great success story led by our colleagues, Dr. Raneem, and also our godfather in geriatrics here, Dr. Hashim Balbaid and his colleagues. So we started the first fellowship program, and then we spread to the Eastern region, and then now we have 2 other programs. These initiatives and efforts are all geared towards increasing the national workforce capacity to improve and work on improving the quality of care delivered to older adults. So what is we talked about the success stories, but we still have a lot of challenges lying ahead. Because as we talked, there are increasing demands for long-term care. We still need around 92 geriatricians to fill the gap if we would like to keep up with our progress and our own, let's say, target, which are always ambitious. And we don't want to be number 6. Our ambition and our goal is always to be on the top. So when it comes to geriatric care and care of older adults, we always want to provide the most integrated, comprehensive, and proactive care. And therefore, we need to continue to work on capacity building across the sector. And we have to do this also with a lot of collaboration with other entities, societies, and we have to do it with allied healthcare specialties, including home health care, including nursing, physiotherapy, and other services, and spread the importance and the impact of geriatric services. Even we still have a lot of effort to be done in introducing the importance and the value of geriatric concepts and principles into the undergrad curriculums or curriculas to ensure that it is introduced early on, and it can be actually adopted and implemented in the day-to-day practice. So there are some basic statistics about older adult services in Saudi. However, we can see that we've talked about the significant that we're still a young country. However, by 2050, I think we are going to be following the Canadian statistics now. So around 19% of the population will be older adults. So if we don't prepare ourselves with services, with capacity, with the programs, we will definitely be witnessing and having to deal with the same issues when it comes to either cost of long-term care, cost of acute care for old adults, and we'll have to deal with the implications and the ramifications of not investing early on in these areas. However, we still have some strong pillars in Saudi Arabia, so that we need to capitalize and leverage. So the Saudi population is a relatively young population, as we talked about. There's a strong cohesion in the family unit with the big family composition. There's availability and accessibility for basic medical services, as we talked early on about these accessible vaccine program nationwide. There is also a recent introduction in the older adult law by King Salman in 2022, and there's a lot of dissemination and a lot of excitement about applying this law across different sectors. However, it needs awareness, and it needs adoption across the respected societies, entities, and healthcare providers. There's also availability of robust social and social services directed to older and vulnerable adults. Also, we have a the presence of a national strategy for caring for all the adults that needs to be actually applied, and there has to be a lot of awareness among us experts about these regarding these strategies, so we can link our programs and initiatives to these strategies, so we have impactful programs that can fulfill each specific objective. So I talked earlier about the success with the healthy expected life expectancy at birth, and how is that actually affecting or will be affecting the healthcare system. However, this could have this metric will have a great indicates or reflects the success of the overall health system, but it comes with a lot of challenges if we don't have strong programs geared towards all the adults and home care. So for those who haven't read the law, all the adults law, please, you can visit this website to understand this important instrument, which is a framework and a strong tool that definitely will support most of the programs geared towards all the adults care, and it should be a strong enabler for most of these services, either medical, social, or otherwise. Because if you understand the responsibilities or the mandates written there, you can definitely leverage each article, and you can stem and branch out from it with a strong basis and foundation. So there are
Dr. Walid, sorry, two
okay.
minutes
So
more.
there are also other regulation and legislation out there for those who are not aware of it. And this slide summarize all these laws and regulation that supports these system, and we must be all aware of it, so we can design programs linked to these laws and understand it carefully. So whenever we design a program, it can be tied to it, and we have a very specific goals geared towards it. The final slide that I want to maybe end with is that in Saudi Arabia we have the Saudi model of care, and in the Saudi model of care, it's something that we're all proud of. It talks about these 6 systems of care that interacts with the 6 layers of care, including an activated person, healthy community, virtual care, primary, secondary, and specialized care. However, you will not see geriatric care represented there, but we always have to, as geriatricians, as advocates, we have to always try to fit in with the existing frameworks and try to use the systems and laws and regulations that I talked about earlier to leverage these frameworks to deliver our goals. And it's I think it's our duty in the Saudi Geriatric Society to ensure that these priorities in the Saudi model of care do not forget geriatric care. I know we can talk about the last phase as a geriatric phase. I mean, people talk about it as the geriatric area of focus, but this to me, it's kind of an ageist point of view, and we need to maybe think about geriatric care from inception. because we should be talking about longevity, we should be talking about healthy life expectancy, we need to talk about like geriatrics from each aspect of as a life course rather than a last phase kind of lens or perspective. So, and there's a lot of room, and I think there's a lot of space for the Saudi Geriatric Society to fill in, or a lot of gap that needs to be filled in terms of standards, in terms of specific micro policies or protocols that needs to be developed to ensure that these initiatives or programs, they are backed up by local protocols and local guidelines to ensure that each of these programs have some sort of backing from a scientific society to ensure that people who are providing them are held accountable according to the best practice, and there are ways to actually monitor and hold people accountable according to local guidelines. Finally, I want to end by
Dr. Walid, sorry,
I'm done.
I'm sorry for interfering, but I think we have
thank you so much. So
overseas guest,
Yeah.
guest that we need to.
Thank you so much for the
Thank you
time,
so
and I
much.
appreciate appreciate being here. I truly appreciate. Thank you so much.
Thank you so much, Dr. Walid. It gives me a great pleasure to introduce our next speaker. My mentor, Dr. Kenneth Rockwood. He is a professor of medicine, geriatric medicine, and neurology, a true pioneer and a clinical research professor of frailty and aging at the Dalhousie University in Canada. He will be speaking to us about how frailty challenges healthcare in aging societies, geriatric medicine meeting that challenge. Dr. Rockwood, it's a great pleasure to have you as a keynote guest. Please, the floor is yours.
Thank you. I'm just going to share the screen. Hopefully you can see. Are you seeing?
We can see the screen. It's on a Word document.
Huh.
So if you can just
let me try again then. Or how about now? Are you seeing the appropriate screen now?
Yes.
Okay, good. Right. So thank you, Suhail, and thank you for the opportunity to speak today. Good morning from me, good afternoon to you. I have been really interested in a lot of the comments and the information that's come from the sessions up till now. So I'm going to start by showing you some information about population aging in Canada. And I'm going to use what's happening in Canada right now as a cautionary tale. And it's interesting that typically when I'm speaking to people from other countries, we're all in the same boat of, for the most part, not having had the foresight to understand what the impact of population aging would be. And hence my title is How Population Aging Impacts Healthcare, because it should not have been the surprise that it is. And you now have time to really take on board the information from here. So this is a typical population pyramid for many of the countries that experienced the Second World War. And you can see here that in 1961, so 15 years after the end of the Second World War, there had been contraction in the population during the war. And sorry, let me just make sure that you can see this with the pointer. There had been contraction in the population during the period of the war. Then after the war, the baby boom was just starting to get going. And then by 2023, you can see there's been a dramatic shift in the proportion of older versus younger people. And so now we're in the position where in 2021, the leading edge of the baby boom began to turn 75. And so we are seeing right away the consequences of that. Go into any emergency department in any place in Canada, and you'll see people talking about, and not always in a happy way, the large number of patients they're having to look after age 75 years and older. But look what's coming, right? This wave will not peak for some considerable time yet. So a lot of what we're trying to do right now is not planning anymore. We're trying to react. And so let's compare that now. The part of Canada that I live in on the East Coast, Nova Scotia, is by the World Health Organization definitions a super aging society. More than 20% of the population is over the age of 65. And that is having an important consequence for healthcare. Let's contrast this with what you're seeing in Saudi now. And so in 1960, you had a more traditional age pyramid without the adverse effect of the war, with many more younger people than there are older people. You can see this is changing as well, and there will be impact on the population, but you have time yet to prepare, time to actually to plan. And I'm going to go over with you what the challenge is like, and then try to show you how it is that population aging acts in such a predictable way to impact healthcare, and what might need to be done, some of the goals you might think as geriatricians you will want to engage in. So what happens with population aging, if you look at the pyramids, the population pyramids, which are those graphs, you can see that, well, there are going to be a lot more older adults. And that's true, but it's not just older adults that are increasing. The number of diseases are increasing as well, and I'll show you that in a few minutes. But the idea is, in classic Greek tragedy, what happens is that the thing that made the hero strong is now making the hero weak. And this is what we're seeing in healthcare in Canada and the US and elsewhere. What has made us strong, what has allowed us to make huge advances in care, is that we have gotten ever better at subspecialized care. So the example I often use is one of cardiology, where it's not just a heart specialty. Within this now, there are a range of subspecialties. And within those subspecialties, some differentiation in that. So take cardiology, a large and growing subspecialty is cardiac electrophysiology. Within that, though the major dysrhythmia is atrial fibrillation, there are whole areas in cardiac electrophysiology that are entirely focused on ventricular dysrhythmias. And so people have gotten better and better and better at caring for these problems. And that's great. But the dilemma is that these problems are not just happening on their own in older adults. They're typically accompanied by many other things as well. And often the price of great subspecialization has been the atrophy of their generalist skills. So don't get me wrong. If someone has certainly a procedure needs to be done, you should be going to a place and having it done where this is done 4 or 5 times a day, not 4 or 5 times a week or 4 or 5 times a month or less. Because as people get used to seeing how these problems work, the teams get slick, is the common parlance for that. They get really skilled at being able to do to work with people who have the particular illness, and then all the variants that go with that, and the predictable ways in which things go wrong with that, and the ways in which you'll have differing responses. They get really, really a great understanding. What is needed, though, is for people to realize that however it's done, many of those patients will be older and they will still have other things wrong with them. In cardiology, again, to take them as an example, we've seen in many places the development of a specialty called geriatric cardiology, where people are skilled as cardiologists, but they've learned enough about frailty care that then they're able to help their colleagues in other parts of cardiology fulfill the mandate of caring for the whole patient. And that is one of the challenges that we have now. And so we are likely to continue to train up people who have specialist skills and enough of the generalist skills that they can serve the needs of their frail older adults. And there's also, as we've heard, the challenge of more people with dementia as a particular challenge of an aging population. So what is this thing called frailty then? So in general, and many of you will know there's sort of two views of frailty. One is the Fried physical frailty phenotype, and the other one is frailty as deficit accumulation. And our group is the deficit accumulation group, so I'm going to concentrate a bit on that, but I think you'll see why, because what I'm trying to get at is quantitatively what is happening with the population. So, but all sides agree, frailty is a multiply determined, so there's more than one way to become frail. It's a vulnerability state, and it arises from the accumulation of age-related health deficits. The approach that we take is really emphasizing that aspect of it. But generally, there's agreement that as the number of healthcare deficits accumulate, the ability of an organism, and I'm saying that now because we've got good animal work on frailty, the ability of an organism to resist stress, which is the word we use for that is robustness, the ability to resist stress, that goes down as people have more things wrong with them. And so does the ability to repair damage, which is to say the resilience. And we've reviewed this paper with Dave Kim in New England Journal in 2024. And so we lay out the argument there for this as a way to think about how frailty arises. So one of the things that we see in acute illness, and I understand from Suhail that there's a gap right now in terms of geriatricians engaged in the acute stages of care. But my goal here is to say geriatric is a big tent. We have many skill sets are needed within geriatrics. We have to have people who understand rehabilitation. We just heard a great talk about pressure injuries. There's the whole thing of geriatric psychiatry and dementia care, the interaction of the medical needs that people have with dementia, with their dementia state, and so on. Many skill sets are needed. But if you've got the opportunity to plan, and it seems that you do, I think that some important part of the planning should look at having geriatricians dealing with patients who are acutely unwell, because acute illness will compromise attention and function and social engagement and being able to walk and not falling and so on. And it does that because as we accumulate deficits, then the functions of humans that integrate all of the things that we do are things like our ability to stand up and walk, our ability to have opposable thumbs, and thereby to do function, our ability to pay attention to the stimulus in front of us while at the same time being aware of things that are going around. And so what we see as geriatricians, you all know this, what you see with illness presentation in frail older adults is they can become delirious very easily. They can have a fall and take to bed. Sometimes we get distracted by the fracture without thinking about the fall that gave rise to that. And all these things also impact on social engagement. So we have to be skilled with each of these ways that illness presents and be skilled with each of the sets of challenges that those problems give to us. And what I'm saying to you now, the extra thing I'm saying is that we also need to see how that operates with acute illness. And I've spent a fair amount of time myself working in the emergency department to look at this interaction between the severity of the acute illness, the underlying degree of frailty. And it's a very considerable challenge, and one I think that is very worthy of the attention of geriatricians. So how frailty is operationalized. So I made the point since 2001, our group has quantified frailty with the frailty index. And as long as you can look at about 30 health deficits in various bodily systems, you'll have a good understanding of how the person is doing, and you can quantify this. And we do it as the number of things someone has wrong with them, the number of deficits that any individual has, divided by the total number of deficits that we measured. Sometimes people are a bit confused about that. They say, what do you mean the total number that were measured? Well, always we're working from a database, right? So it'll either be a health record or an epidemiological survey or some such. So we want to look at everything that's been, all the information that has been collected, all the individual points, and then see how many of those are in the deficit state. And when we do that, around the world, understanding that people are measuring different things because they're measuring things that are relevant to them. So the point I sometimes make is that here in Canada, particularly on the East Coast, particularly further east where I was born in Newfoundland, where there's a lot of snowfall, it's really important to understand how people are handling the snow shoveling. And it's very important to understand, can a person, typically a man, put the ladder up to climb up on the roof in the middle of the winter and shovel the snow off the roof? Because if you don't, the snow can accumulate to such an extent that the roof will collapse. So that's a very high order function. And so we spend time thinking about, how we should measure that if we're going to look at frailty. You wouldn't need to do that in Saudi though, right? But you would have equivalent things that help you understand the extent to which the earliest high order functions that people have has become compromised. So when we do this, like the number of deficits divided by the total number of things that were measured, we get this very characteristic change. So this is starting actually from age 15 is when aging starts, but across the life course on the x-axis is age, on the y-axis is the degree of frailty. The black line in between is the average frailty index, and unsurprisingly, that goes up with age. But I want to draw to your attention that other things are going on, and variability is increasing as well. And there's really something here around the age of 75 where you see more variability. So what happens at the age of 75? So these are data from Sweden, from a fracture registry there, looking at hip fracture across the life course. So blue is male, red is female. You can see that early on, there's a big male preponderance of that way. By the time it comes to about 50, women have more fractures than men do proportionately. But at the age of 75, all of the chance of hip fracture goes up for both sexes quite markedly. And we can do this for any number of diseases, heart failure, repeat hospitalization for COPD, all those sorts of things. But just to make the point that, and here's kidney disease, and it too is going up at the age of 75. All the graphs for illness look either like the hip fracture ones, where it's a life course issue, or the kidney ones, where we're looking at disease that typically is uncommon when people are young, gets very, very common after the age of 75. And so I say to people, there are so many diseases that increase at the age of 75 that the challenge for healthcare is that there's not enough people to go around anymore. There are many more illnesses than there are people. So that means that many people have more than one thing wrong. So now think back to your internal medicine training, those of you who did that, the amount of time you spend in hematology and nephrology and gastroenterology and so on, learning about that aspect of the trade. And how often did you see people taking with a glad heart their patients who had what they were interested in, all these other things wrong as well. So what happens is at the age 75, that's when variability increases. And the variability in relation to age is what defines the degree of frailty that people have. So what we see is, if we look across the life course, how frailty manifests clinically changes as the degree of frailty increases. So here's someone who's very, very fit, and then we look going across the life course, and here's someone who's very, very frail. So this person lives with severe frailty. This person isn't frail at all. They're quite fit. And the reason that these numbers are so small is that this is done to represent what happens in an acute care population. Comparatively few very fit people coming in, comparatively few very severely frail people coming in. Lots of people in between who will need more help than any one specialty looking only at the one thing that it does is going to be able to deliver. And that's why we have geriatrics. That's why geriatrics is a team sport, because we have to get in, take all these things into account with people. Now I want to switch a little bit for dementia. So I was interested in the prior presentations about different types of dementia and so on, very interested in the idea of integrated care as well. But this is a real challenge for the way we think about dementia if we're trying to do it one disease at a time. So these are data from 6 community-based autopsy studies that looked at 6 different types of neuropathology. And these different groups are the number of types of neuropathology that people had, 0, 1, 2, 3, 4, 5. And so look, this is dementia. So there are some people, even with very little of the traditional neuropathology, who develop dementia. But generally, if you don't have dementia, if you don't have any neuropathology, the chance that you get dementia is low. And same way if it's only 1. And even at 2 types of neuropathology, it's still the case that most people with that pathology do not have dementia. It's only when you get to many, many types, all 6, 5, or 6, that you'll see that people have dementia virtually always. So there's a mismatch, well-known mismatch between what a brain looks like under the microscope and the chance that person had dementia. So over against the idea that neuropathology was the gold standard, we know there's a gap. And the point to talk to you about this as geriatricians is that much of that gap is filled in by frailty. So here's some work from our group working with David Bennett and the Rush group in Chicago. Here's Alzheimer's pathology on the x-axis, the chance the person had dementia on the y-axis. And these 3 bands are 3 levels of frailty. This is people who are generally didn't meet frailty criteria, had a moderate, mild to moderate degree of frailty, and now here moderate to severe degree of frailty. And at all stages, you can see that the people who were fit did better, had a lower chance of developing dementia than those who were frail. And then we also looked at what about how lifestyle factors play in with so we looked at genetic risk, and you see the same thing here. So here's people with a low degree of frailty and high polygenic risk versus a high degree of frailty and high polygenic risk. You can see that there's quite a gap here in terms of the risk of dementia. So frailty moderates neuropathology, frailty moderates biomarkers, frailty, which I haven't shown, frailty moderates polygenic risk. And it's important, there are important sex differences as well. We'll skip over that now. What I want to say is that we know that frailty can, that people who engage in healthy lifestyle behaviors tend to be fitter. They have less of a chance of frailty, and much of that is mediated. So less chance of dementia, much of that is mediated by the degree of frailty they have. So this is people with higher frailty index scores, where the impact of the lifestyle behaviors there they've engaged in none is mediated by the degree of frailty. Here they've engaged in all, that these people have a lower degree of frailty, both men and women. So frailty is having an important part for moderating risk and mediating the benefit. So frailty is not a disease, but it profoundly influences disease expression. What we've known is that if you have a healthy brain here and a healthy body, dementia risk is very low. That's been known for some time. If you have an unhealthy brain, we know the dementia risk is high. But the new information is that you can have an unhealthy brain and you can lower the dementia risk through a healthy body. And that is an important factor in understanding why we see what we see and what the consequences might be for single disease approaches. So to sum up, frailty is a multiply determined age-related vulnerability state. Frailty moderates risk and mediates benefit, including in dementia. And for the future, equipping acute care to provide frailty-informed care is an important goal. And that work, the data suggests, is best done with geriatricians being at the pointy end of care. And the second important challenge of population aging is dementia It typically has multiple pathologies. It's treatable, especially in its very mild to moderate phases, but we have to take a holistic account for that. And so I'll end just by thanking all the groups who have funded me over the years, thanking the colleagues, the students who become colleagues, and so on. And particularly, thank you for the invitation to speak today. Thank you very much.
Thank you so much, Dr. Rockwood. It's really a great pleasure to have you with us today. And an interesting talk as usual. Thank you so much. Thank you to Dr. Walid and thank you to Dr. Ali. We are here opening the panel for questions and answers. Please write them in the comments or raise a hand so we can allow for a direct interaction with the speakers. Dr. Walid Al-Khredi, please.
Thank you so much. I would love to thank Prof. Ken for his presence today, and it's really an honor to be standing and presenting before him. And his presence and presentation today adds a lot to us as geriatrician here in Saudi and to the conference as well. I just had a question about if it's okay to bring that slide that you talked about, where you talked about the mixed pathology and frailty. The key message was regarding that it's not about the mixed pathologies that moderates the outcome, and it's more about the frailty. I think I think I kind of didn't get the bottom line from that slide. If you can just maybe explain it further, I would really appreciate it. And how can we perhaps work towards addressing that from a, let's say, to modify that, like for from an intervention point of view? Because I mean, if we want to address the mixed dementia part, there is a lot of efforts through the finger and the pointer studies with the multi-domain interventions. How can we do the same thing if frailty is the key driver here? Does the same methods and interventions apply if we take that approach or not? Thank you so much.
Yeah, that's a great question. So at the moment, I'm engaged in 2 clinical trials that are trying to evaluate better approaches to dementia prevention. One of them is so they both have the thing that we know to be the case, and there's multiple studies that have shown this to be the case. In Canada, we had a study called the Synergic trial led by Manuel Montero Adaso at Western, and that combined education tailored for the individual with some information about lifestyle modification and also with exercise. And those things were found synergistically to work. There's a 4th arm of that had vitamin D that didn't seem to add any particular benefit. So what we're doing in our trials is we're saying, well, everybody should get that. Now let's add something else on. And in one, we've got an increased protein supplementation and then we've added blueberries, which have a lot of well worked out nutritional benefit, including antioxidants and various other things. The other trial we're doing is a prebiotic replicating work that was done in the UK in the twins study to add that on. So the approach I would take is that if these things work, this becomes the baseline. So because frailty moderates risk, if you can reduce the degree of frailty, you should be able to reduce the degree of cognitive impairment that people have. And we have many tantalizing hints towards that in the non-pharmacological domain. Our group is really interested to work in that because we also, in virtue of clinics that we do, and we put together a group of people who have access to the same, we're able then to test this in relatively deprived populations, so the poorer parts of Canada, who typically do not have the same uptake of the lifestyle interventions and such. So there's a strong social component to it as well. So what we're saying is that everybody should get this type of disease-modifying therapy, which is to say exercise and nutrition and social engagement. And then on top of that, we could layer in the other aspects that we're trying to teach, as trying to test. And so I was very interested in the presentation by Dr. McHale, and I'm blocking on his last name now, but the man from looking through the list here, from George Washington University and Integrative Medicine, about, I think, a similar type of approach, although I confess I'm a one thing at a time guy, but when we're trying to look at the new interventions. So the bottom line would be, we should do the things that are going to affect multiple domains and use that as the basis for any other treatment that we want to add on top of that, recognizing that there will be a very different approach, whether you add one thing at a time or a bunch of things at a time. But I think what the two approaches would share is that you can't just do one thing, that this is not going to be a single protein abnormality is going to take care of everything. While we can see that with younger people, that's not what late life dementia is. Late life dementia is a number of different pathologies that are going on. And the more of those pathologies that are active, the higher the chance that an individual will not be able to resist that pathology. So they won't be able to cope with it.
Thank you, Dr. Rockwood. I think you're referring to Dr. Kogan, who was presenting.
Yes, Dr. Kogan, yes, sorry, thank you.
From the US. Okay, we'll move to the next question. We have Dr. Tarad is asking a question to Dr. Rockwood. There is a lot of talk globally about longevity, with a lot of innovation and proposed services and products. Besides doing lifestyle modification, exercising and diet, etc., what are the best evidence-based interventions that falls under services and products of longevity that would improve frailty from your perspective?
Yeah, I don't know. I've been party to some of the longevity discussions. There is a whole phenomenon of anti-aging medicine, and certainly online you see a huge number of claims that are being made. So nothing out of the things I have enumerated thus far has come to my attention, and I'm staying alert to this. Is one of the things with the endocannabinoid tone. It new to me. I've taken a bunch of notes about that and plan to look into that more. So what I've been doing is staying alert to what things we might be able to put into trials, and hence the two trials that we've got going on just now. There is an historic tension between people who have been doing work on longevity and people have been doing work on the basic science of aging. And back in the 40s and 50s, a huge amount of work was done to try and make biogerontology respectable by saying, no, we're not looking for the fountain of youth. We're trying to understand the various ways in which aging itself is proving to be a problem, and what lessons we need to learn from that to tackle it at that level. So when I started training in the 80s, this is still an important part of what we were all talking about. So I carry that prejudice with me. I'm interested, though, in the people who are taking a different approach to looking at so-called health span. So the geroscience revolution, where people are imagining that through things like tackling the pillars of aging or tackling the hallmarks of aging, they'll be able to produce impact on many of the late life diseases. I'm partial to trying to understand how that plays out, but at the moment, I'd keep my eye open on the senolytic trials would be the area that seems to be the most mature thus far, and in the aging and the anti-aging space, the respect part, the geroscience bit, I would also keep my eye open for the markers of the type of inflammation that seem to be associated with many of the chronic diseases that we see in late life.
Thank you so much. A question from Dr. Anas. The 65 years old threshold for frailty assessment reflects largely Western demographics in population with higher chronic diseases, biological aging as such in Saudi. What do you think or should be the threshold lowered to 55 or 60, and how to determine the population-specific age of elderly, reflecting on the frailty index distribution that you're an expert at?
Yeah, so again, another excellent question. So we've published, deficit accumulation occurs across the life course, right? And so that's why we got into, and very controversially at first, the idea of calculating frailty index in 20-year-olds and such. It appears to be informative across the life course. What makes it striking on a population standpoint is where the variability increases. So the first thing that I would do if I had access to population data for a country and wanted to look at when we should really start to devote resources into this multi-domain frailty style care, the team sport that is geriatrics, I would look at the point at which there is variability in the distribution of the frailty index scores. Where does that take off? You can see that the data from Canada, 65 is even young for that. It really starts to take off at the age of 75. So I would be inclined as an approach to look at the data for Saudi, for example, and say, do we have a comparable set of survey epidemiological data? That's where you need to get information from. I think hospital data would be somewhat misleading on that. If it's all you've got, you could make enough assumptions to tackle it. But I think that would be an interesting approach. I just want to make one other point, which is that frailty was introduced in the medical literature in 1979, in the health medical literature in 1979 by actuaries, by people who were demographers, and they were trying to look at the death rates, and they made the observation, they were able to quantify it, that not everyone at the same age had the same risk of death, and there were people with multiply determined problems. So not that someone developed cancer, but someone had more of the frailty profile with a bunch of things wrong all at once. And that would exist across the life course. That's where the term frailty came in originally. It was then generalized to be variability in the risk of death for people that with the same degree of exposure. And so the cancer people took that up first. They wanted to know why their staging algorithms and their staging classification systems were still not explaining a lot about cancer, and they knew that it wasn't just the lethality of the cancer itself. And so that's where a lot of frailty work was done, just from a statistical concept. What we self-consciously tried to do in the late 1990s was to figure out a way that we could operationalize frailty that would take into account all the work that had been done about frailty's variability and the risk of death for people of the same age. And that's how the deficit accumulation came about.
Amazing. Thank you so much. There are two more questions, but I will. I apologize to the attendees. We have to take a short break before we continue to the next session. Thank you so much, Dr. Rockwood. It's a pleasure to see you. Thank you so much, Dr. Waleed, and thank you so much, Dr. Ali. Inshallah, we'll take a short break and then we'll continue with session 5 at 3:30. Thank you.
الحزام الناري يترك الكثير من الناس يعانون لأسابيع. هذا الطفح الجلدي يجعل ارتداء الملابس أمرا مؤلما والنوم مأساة. ولكن هذا ليس أسوأ ما في الأمر. هذا الألم المنهك يجعل الناس يفوتون اللقاءات ووقت العائلة وحتى اللحظات التي لا تأتي سوى مرة في العمر. ولكن حتى هذا ليس أسوأ ما في الأمر. الأمر الأكثر إحباطاً بشأن الحزام الناري هو إنه من الممكن منعه. لقد طفح الكيل. كفى يعني كفى. يكفي أن شخصاً واحداً يعاني من الحزام الناري هو كثير جداً. لقد حان الوقت لأن يسمع كل مريض عن الوقاية من الحزام الناري. معاً يمكننا المساعدة في حماية الملايين من هذا الألم الممكن تفاديه. الآن هو الوقت المناسب. السؤال: إذا كان بإمكانك منع المعاناة بسبب الحزام الناري، لماذا لا؟
Assalamu alaikum wa rahmatullahi wa barakatuh. We are here back to our last session. Really gives me a great pleasure to introduce my colleague as the session moderator, Dr. Tahani Tamimi. She is a consultant in geriatric medicine, associate professor of College of Medicine, University of Hail, and she is the deputy chair of the board Saudi of Geriatric Society. I'd like to first thank her for all her efforts and dedication leading the leadership of the society, and I will give her the speaker to introduce our next session and speakers. Thank you so much.
Thank you so much, Dr. Suhail. Good afternoon, everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the final scientific session of the conference. So we're going to have 3 distinguished speakers, and I'm pleased to moderate this session that themes about polypharmacy, cardiometabolic health, and falls in older adult. Our first speaker is Dr. Amber Zulfikar. Dr. Zulfikar is an accomplished physician and educator and academic leader from United States. She served as a director of longitudinal integrated clerkship academics, plus director of the foundational and clinical sciences integration, and is a clinical associate professor. Today, she will discuss one of the most critical challenges in geriatric medicine, which is polypharmacy, and the pharmacological complexity involved in caring of elderly. Please join me in welcoming Dr. Amber Zulfikar. Dr. Amber, the mic is yours.
Hello, Assalamu alaikum. Can you see my screen?
Yes, we can see it.
And you can see the slide?
Yep. Yes,
Okay,
you
great.
can go.
All right. Thank you so much. So, like I said, Assalamu alaikum. I would like to thank Dr. Khalid and Saudi Geriatric Society for giving me this opportunity. And a special shout out to Aya because she's been assisting me with my presentation. I do not have any conflict of interest to declare. So these are the objectives for my presentation. All right. So before we dive into the data, I would like to align some definitions. Number one would be, what is polypharmacy? So I'll also be talking about some of the acronyms, which I'll be using throughout my presentation. So starting with polypharmacy, most commonly it means 5 or more medications, but there is no universal standard definition. There are about 138 definition that exist in literature. So what matters clinically is the distinction between appropriate polypharmacy and inappropriate polypharmacy. So example being that if there's a heart failure patient and that patient is on 4 guideline directed therapies, that is an appropriate polypharmacy, as opposed to a patient who is taking diphenhydramine for sleep or insomnia when cognitive behavioral therapy for insomnia is available, would be an inappropriate prescribing. So what we really have to target on are medication which are PIMS. These medications, which are potentially inappropriate medications, are generally supposed to be avoided in people who are above 65.
Dr. Amber,
Yes.
can you move the slides? Do you have the control to move them?
Yes.
Still, we are in the first slide.
I'm sorry, can you see this one now?
It's the first slide, your name and the topic.
Yeah, so I'm actually moving the slides from here.
Oh.
On my end.
Aya, can you control?
Yes.
Yep, now it's moving, yes.
Okay, wonderful. All right, so sorry. So like I was saying that we are supposed to be targeting the potentially inappropriate medication, which are by definition, they're supposed to be avoided in people who are above 65 years of age. And there are 3 reasons for it. Number 1, because they're ineffective. Number 2, they pose unnecessarily high risk. And number 3, there are safer alternatives that exist. Another terminology which I will be using is potentially prescribing omission, which come under the umbrella of potentially inappropriate, inappropriate prescribing. What potentially prescribing omission means is we do not prescribe medications which are clinically indicated. So an example would be that a patient has heart failure and we are not prescribing an ACE and ARB just because of the age. Another term I will be using will be adverse drug events, which are actually clinical harm resulting from PIM exposure. So consequences of polypharmacy, the evidence. Why do we care about polypharmacy? So the data has shown that patients who are on 5 to 9 medication have nearly twice the odds of experiencing an adverse drug reaction compared to those who do not or who are on fewer drugs. This goes up if there's somebody is on more than 10 drugs. Then the odd becomes over 3 times. So it shows a clear dose-response relationship, meaning the more medication a patient takes, the higher the risk of adverse reaction, hospitalization, and death. So why does this matter? The Saudi context. Polypharmacy is a rule, not the exception, which means that it is routine. It's not rare. It's something which demands proactive management. And managing polypharmacy is a core responsibility in geriatric medicine. And it's not an occasional challenge. We see it all the time. So based on Saudi, it's been projected that Saudi elderly population, which is age of above 60, will increase to 3-fold by the year 2030. And there was a survey done by Saudi National Survey for Elderly Health, which showed about 51.5% of community dwelling older adults use more than 5 therapeutic classes. The most striking data here is from Al Noor Hospital, Makkah, which shows that about 97.2% elderly who were hospitalized were on medication, and out of them, about 77.6% were on more than 10 medication. And the most commonly prescribed medications were paracetamol, NSAIDs, anti-diabetics, and multivitamins, which means to me that polypharmacy is not just a Western problem. It is also affecting Saudi Arabia as well. But the Saudi-specific drivers, of course, are different. So what are the risk factors for polypharmacy in Saudi older adults? Who is most at risk? So if you look in this slide, the dominance of musculoskeletal pain is one of the top predictors, and that's unique and reflects high NSAIDs used in Saudi Arabia. Older adults who have musculoskeletal pain of any kind are 2.28 times more likely to receive PIM compared to those without pain. And this is the strongest predictor because pain management in the elderly frequently involves medications which are on the BEARS or stop lists, particularly NSAIDs because of their risk of causing GI bleed or renal injury. Apart from NSAID, we also use skeletal muscle relaxers for pain, which can lead to sedation and falls. Same thing if you look at diabetes, there's another medication, another class of medication which can result in polypharmacy and cascade prescription. One of the ones which I would like to draw your attention to is hypertension. That because we use multiple antihypertensive medication, they lead often to orthostatic hypotension. If we look at urinary incontinence medication, these are 1.39 times more likely to receive a PIM. And then again, we know that if we give anticholinergic, that can result in cognitive impairment, confusion, dry mouth, which again, like if you look at it, the conclusion is more chronic diseases a patient has, the more medication they take, and the greater the chance that at least one of those medication is inappropriate. This is a slide which is showing the systemic review of a Saudi study, which shows the prevalence of prescribing inappropriate medication. Again, if we look at Baroda Central Hospital data, we can see that there are about 66.25% prevalence on PIMS by Beers List. The most common of that is again NSAIDs, then baclofen, followed by PPI, diuretics, and aspirin. We can also, we know by data that about 55% of Saudi elderly who live in outpatient setting have high fault risk. And polypharmacy is significantly associated with that geriatric syndrome. Also is observed is medication and non-adherence. About 63.4% of those patients who are prescribed more than 5 medication, they reported non-adherence versus 36.6 who were on fewer. So then the question is that what is going on? What are the things which we have to be aware of when we are taking care of our geriatric population, especially in the context of a medication prescription? So as we know that one of the factor is that as non-adherence in this population, then absorption in the GI tract decreases because of reduced motility, and reduce blood flow to it, which results in, I'm sorry, I can't see this clearly. So those are some of the factors which lead to decreased absorption of the medication. Distribution is also affected because of leaner mass, increased body fat, which of course affects the volume of distribution, and some of the medication which are lipophilic tend to stay longer in the body, hence causing side effects of the liver mass decreases, the blood flow decreases, so metabolism of the drugs are affected. And last but not the least is the changes which are happening in the kidney. Because of the decreased blood flow, and again, because of the changes in tissue histology, the drugs which are in the system, they get eliminated slower and lesser. Then what are the pharmacodynamic changes with aging? So increased sensitivity and impaired compensation. So one of the things is that the pharmacodynamic changes are more often clinically impactful than pharmacokinetics. And the challenge is that they are harder to predict because every patient is different. So if you look at the first class of medication with anticoagulants, because of the increased sensitivity, the higher risk of bleeding at standard doses, and then we have to closely monitor INR and lower the dose targets for this group of population. Benzos is another one which increases the sedative effect. Age increases the sedative effect at equivalent plasma levels, which again can lead to fall, cognitive impairment, and paradoxical agitation. We already talked about antihypertensive. Of course, with age, the baroreceptor reflex goes down. So that's why we have exaggerated orthostatic hypotension. So the key mantra is that we start low, go slow, but do not stop too low. So as a clinician, the goal I have in my practice is, of course, number one is do no harm. So what I have been using for a while is the 4Ds approach. This is in alignment with what my goal for every patient visit is. So when I'm seeing patient in my clinic, the 4Ds I follow is, number one, I want to detect or diagnose a disease early. And if I'm able to do so, then I also want to make sure that I prevent complication. The second D is for preventing disability. The third is to prevent dependence. And the fourth, by the will of Allah, is to prevent early death. So the same Ds I use for polypharmacy when I'm looking at my patient's brown bag, which every single time they come in, the number one thing we do is medical reconciliation, making sure we are not harming the patient. So with that, I look at the medication and make sure that if there is a valid current indication for that medication, is the drug right for the age and comorbidities. I look at the Beer Stop list, making sure that I avoid the medications on them or at least pick an alternative choice, and then check for therapeutic duplication. The second D is for the right dose, in which making sure that the doses are adjusted based on the GFR of the patient, as well as if there any liver condition going on, taking that into consideration as well. Then the third thing is right duration. So is the long-term therapy still needed? With that, I consider the time to benefit versus life expectancy. So if people have shorter life expectancy, for instance, less than 2 years, then statins, if they're used for primary prevention, are something which I would avoid, because at least that much time is required for statins to show the outcomes. And then very simple medications like PPI need to be avoided for more than 8 weeks without identification of the or indication. The last D is for very, very important, which is the right deprescribing. So making sure identifying and stopping any unnecessary drug, taper when withdrawal risk exists. And there has to be a shared decision made between the patient and the adults. You'll be amazed to know that about 88% of older adults are willing to reduce their medication. Which this is another framework, which is the geriatric 5M frameworks. I'm pretty sure all of you must be aware of this one, which is a patient-centered approach to every geriatric encounter. And with the current 2025 Bayer list update, AGS has also commented to use this as part of polypharmacy prevention. So the different M's are here. So the first M again is for medication. Is each medication still needed? That is the right drug, right dose, and right duration. Mentation, they talk about, is cognition affecting adherence, or is there a risk of the medication causing any changes in mind? Mobility, are medication causing falls? Multi-complexity, are drug interaction creating them? And then what matters most in addition, which is what are the patient's goals? What are their preferences? So this framework is actually a bridge between evidence and patient-centered care. Every medication decision should be filtered through what matters most to the patient, which is very, very important. So drug-drug interaction Saudi data. The hidden danger in every prescription, based on what Al Noor Hospital Makkah, we saw N of 143 patients there. 85.3% of patients on 2 or more medication had at least one potential drug-drug interaction. Example is one of the category X. Most common is clopidogrel and omeprazole, which is given together. Omeprazole inhibits one of the enzymes which reduces clopidogrel conversion to active metabolite, and it decreases the antiplatelet effect and increases the thrombotic risk. So it pretty much is not doing what it's supposed to do. So action required is to switch to pantoprazole, which does not affect that enzyme, or use H2 blocker. So only 10.8% of pharmacists in Jeddah reported adequate PIM knowledge, and only 14.7 use screening tools routinely. The first generation antihistamine rate, which is 46%, is striking and higher than rates reported in most international data. So a combined educational plus clinical pharmacist intervention and KAMC reduced PIM incidence from 61% to 29.5%, which proves that change is possible. Now, what are the different screening tools for inappropriate prescribing? Like we said, a systematic approach to identify. So these are some of the tools which are available out there. Bayer's and start criteria are the two ones which I use, and they are complementary. Bayer's is a drug-focused tool, and stop and start is a disease-focused one. There's another one which is called Stop Frail. This is specifically designed for the frail elderly and with limited life expectancy. And of course, you can see there's medication appropriateness index, which is a little bit time consuming because it has 10 elements assessment. So it takes at least 10 to 15 minutes on one drug. Then there's ARMOR framework. So one of the most important thing which we have to take into consideration is that the single most important question when we are prescribing in our geriatric population, could this new symptom be caused by a drug? How often do you think we ask this question before writing a new prescription? And this prescribing cascade is the most under-recognized driver of polypharmacy. One of the examples I put here is medication which is used for high blood pressure, amlodipine. So we prescribe amlodipine, ankle edema, we see on examination. Now we want to give patient a diuretic like furosemide, which patient ends up having hypokalemia. And we add potassium supplement. Lo and behold, it's one drug side effect and we have 2 unnecessary medications here. So prescribing, it's a therapeutic intervention. It's not abandonment of care. 88% of older adults, like I previously mentioned, are willing to reduce medications when recommended by their physicians. So again, we have to have the 8-step deprescribing process, which we just talked about, making sure compiling a complete medication list, which includes both over-the-counter medication, herbal medication, and supplements. The second step is identify high-risk medication using the Beer-Stop criteria. The third is assess in each medication still there, if there's still an indication, is the dose appropriate for age and renal function, is there a safer alternate? Consider time to benefit. Will the patient live long enough? Prioritize stopping medication with highest harm to benefit ratio. Taper gradually. There are some medications which we have to take time, for instance, beta blockers or PPI or steroids. Monitor for withdrawal effects and disease occurrence. And then, of course, the last one is communicate. Always have a shared decision making with patient and family. Time to benefit is a very powerful concept because what we talked about, just giving an example of statin. So these are the key Beer's criteria highlights. I'm sure all of you are aware of these. I would like to again focus on the aspirin. So if you look at aspirin recommendation, it is particularly relevant because many Saudi elderly are still on aspirin for primary prevention. And the rivaroxaban flag is also important. So these are AFP highlights from 2023 AGS Beer criteria, and which showed that in 2023 they made a lot of notable changes, and one of them was antithrombotic class of medication. Here I have added 2026 AAFP age-friendly assessment and 2025 AGS position statement. Again, if you look at age-friendly geriatric assessment, again, you can see the 4 M's there. What matters most: patient goals, medication, use Beer's criteria, as well as stop-start recommended review tools. Mentation, always screened for depression, delirium, and dementia, which impacts medication safety. And mobility, which is fall risk assessment. Medication are the most modifiable risk factor.
Dr. Amber, 1 minute left.
Yes. Okay. So impact, again, we'll quickly go through this one. 19 to 80% of PIM prevalence across Saudi. So if you look at insomnia, for instance, or we were talking about chronic pain, so instead of giving them NSAIDs, topical NSAIDs are available. Those are underutilized, and they are much safer alternatives. So conclusion and call to action. If you look at it, we know the problem is polypharmacy. Of course, PIMS is there. We have some changes related to aging, so individualized dosing, being aware of prescribing cascade. And then what do? Integrate Beer stop-start list into Saudi EHR system, expand pharmacist-led medication review, adopt the 5 M's and the 4 D's framework. And this is the key takeaway. Every medication is guilty until proven otherwise. Always ask, could the new symptom be caused by a drug? Apply the 4 Ds and the 5 M's at every visit. And deprescribing is evidence-based medicine. It saves lives and reduces harms. Thank you.
Wonderful. Thank you so much, Dr. Zulfaqar. It was very insightful and highly practical presentation with the updated statistic in Saudi Arabia, how to cover and manage the polypharmacy and the PIMS. Now we're going to move to our second presentation, which expand on the broader multidisciplinary approach to safer aging and full prevention. It's my honor to present my colleague, Dr. Suhail Al-Amri. Dr. Al-Amri is a consultant in internal medicine and geriatric medicine, and he's a head of geriatric medicine division, and he is an executive board member at Saudi Geriatric Society. Today, he will discuss the cardiometabolic care and full prevention with more detail, how to improve it and prevent the complications. Please, Dr. Al-Amri, you can start.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Tahani. Thank you, Dr. Amber. It's a great pleasure to present at this conference, and thank all the involved parties in making this successful, from planning to organizing and execution, speakers, attendees, from cardiometabolic care to falls, the multidisciplinary pathway for safer aging and healthy aging. Today, I want to challenge myself first and also the attendees in a very familiar assumption in our general practice that often we see falls in older adults, and we see that those falls are inevitable. Actually, I will argue that many falls are not only disease-driven, but also care delivery driven. And hopefully we can, at the end, engage in a most fruitful discussion about how to implement change and promote healthy and safer aging. Let's start with Mrs. Fatima, who's 84 years old widow, lives alone in Riyadh. Her daughter visits her twice a week, and she receives medications through primary care and Ministry of Health Services. She was brought to the emergency. She had a slip and fall in the bathroom while getting up at night. She was conscious but sustained a painful bruise over her left hip, the usual case scenario that we face. She has been unsteady for months. She didn't bring it up, and now she is in hospital. Medical history is a little bit complex: hypertension, diabetes, osteoarthritis, osteoporosis. She has mild cognitive impairment, some neuropathy, cataract and reduced vision, urinary urgency, and some depressive symptoms after losing her husband. She's on many medications, as you can see, and her functional history, social history, there's a struggle. She uses a cane and constantly walks slow and fears a fall, avoids leaving home, difficulty climbing stairs, eats poorly. She has lost some weight. Some messy environment around her with rugs and carpets, poor lighting, footwear is not at best. When we did the examination, she has some surprising or interesting findings in the vitals, maybe pointing to some orthostasis. And in the physical examination, she has some gait abnormalities, difficulty rising from a chair, quadriceps weakness. She has decreased vibration senses. She has a positive tug exam. She has some changes in the mini-cog, visual acuity. What I'm getting to is hopefully by the end of today we can define this syndrome that comes frequently in healthcare as a preventable syndrome. And we should also focus on how these syndromes or recurrent events functionally impact chronic disease management, and dissect into some of the guidelines in that regard, and eventually light on the suggested multidisciplinary team work or care pathway. So a fall is a geriatric giant. You don't need me to tell you that. 30% of our beloved elderly, they fall annually, and this is a huge percentage. About 15% of those falls resulted in a serious injury, and about 30%, like the third of them, 1 year after hip surgery, the mortality actually increases. So nevertheless, talking about the functional decline and functional impact of that, and it's all documented in our literature. I would not like to blame the system for this, but this is just maybe a catchy title. We tend to think it's accidental, but actually they are not. Those falls are predictable, multifactorial. Most importantly, we can work together as a team in our healthcare facilities to prevent that, in changing how we assess risk and prescribe and coordinate care. We'll take a journey to some of the cardiometabolic links to those falls, and get a ride through some of the guidelines that we deal with almost every day. So there has been a link between overtreatment and fall risk, whether that results in a hypoglycemia incident or orthostatic hypotension or polypharmacy, as Dr. Amber have beautifully detailed in the previous note. 30 to 40% of those falls are medications related. And this is something very alarming that we have to keep in mind whenever we come across a geriatric or comprehensive geriatric assessment. So the problem, as I see, and we'll have a discussion after all at the end, I don't think the problem is with the guidelines, because the knowledge that we have now is supreme, but it's actually about the execution. The gap is in the execution. Risk identification that we use in clinical practice routinely should be systematic, not intuitive. A medications review should be proactive, not reactive to some incident or a request. Frailty assessment must be integrated in our system, not an optional or a by chance privilege that a patient will have and the other will not. If we go through the main chronic diseases management, starting with hypertension, most of the current evidence that we have is from the SPRINT trial, and no doubt that there is a cardiovascular benefit to tight control of blood pressure. But if you dive through the guidelines and the trial, you can see some in the details that would make you rephrase or reframe your practice to more individualized and person-based care. As intensive systolic blood pressure control, there is no doubt it can reduce cardiovascular risk. Mild to moderate frailty were included in this trial and the post hoc analysis. The frailty increases the risk of absolute risk, but did not diminish the relative benefit of the treatment. However, because frailty analyses were post hoc, and the severely frail patients were, or institutionalized or bedridden patients were largely excluded from those trials, clinicians should apply some careful eye applying those targets to those patients in regards to functional tolerance, functional status, tolerance, and patients' goals of care and priority. Moving to diabetes, maybe it's more clear now in the diabetes world that frailty is considered as a major modification or modification factor in our treatment. There is no doubt that tight control can prevent and delay micro and macrovascular complications. But if we see the glycemic control for those patients, moderate, severely frail patients who are bedbound, etc., with less than 7% or 6% of HbA1c, you can see there's a huge risk of hypoglycemia and adverse events. So now there is more liberate targets for those patients, and where all the guidelines considering that matter has actually clearly stated that we should move to more individualized based targets and plans. Going to dyslipidemia, maybe that's not a much a direct effect to fall risk, but it provides the guidelines provides a high quality evidence based on the recommendations, especially for statin, particularly for second prevention and for patients with diabetes or established cardiovascular risk. However, treatment intensity and strength of those plans should be individualized according to frailty, severity, life expectancy, polypharmacy, and patient's goals. Frailty should be automatically preclude, should not automatically preclude statin therapy, but we should look carefully to the patients. Consideration to anticipated cardiovascular effect, time to benefit, do they have side effects of the medications, and how that is affecting their daily function. Moving forward to acute coronary syndrome management, we should know that there is an increased risk, maybe 2-3 folds more to bleeding rather than the general population we treat for, especially with patients with frailty. And the most recent paper on beta blocker on patients with stable post-ACS status with normal ejection fraction, there is actually no added benefit continuing those medications. And On the other hand, there is risk of orthostatic hypotension, syncope, fatigue, and eventually falls. So what I'm trying to promote here is not a single man or woman show, or a single physician show, let me say that. Multidisciplinary care pathway for geriatric care is a standard of care, and we should promote it whenever we practice and whenever we talk or engage in discussions. And it starts from primary care level, where primary care should detect the risk, identify it, and then initiate the pathways that we have implemented in our system. Hopefully, at some point, clinical pharmacy and pharmacies can join into reducing the iatrogenic burden as a second line of safety net. And then the geriatrics multidisciplinary team, not just the geriatrician, aligns the care with frailty and with function and with goals. Then goes back to primary care to close the loop on the continuity of care and make sure that there is a sustainability to that. And in this circle, not more care, it's not more care, it's not more burden on the healthcare system. It's actually better sequence care that would eventually lead to more or improved quality of life for our patients, less adverse events. And actually, even the healthcare system will benefit from that, with less hospital readmissions, less falls, less interventions as much as we can. And as you can see, if they are, if they can be prevented and addressed in earlier stages. So what are we talking about in regards to interventions? Are really highly impact clinical interventions, whether that by deprescribing or engage, let's say not in deprescribing, but the more appropriate word is engage in appropriate prescription process or prescribing process. Look at the sedatives, the overtreatment, the unnecessary continuation, align that with the goals of care and the functional status, and make sure that the medications list, whenever we come across an encounter with an elderly person, are a cornerstone in our assessment. Recalibrating the cardiometabolic targets, trying to avoid as much as we can the major causes or risks of falls, whether that orthostatic hypotension or hypoglycemia, sedation, dizziness, neuropathies, etc., where we can also base our assessment and our decisions on the frailty and life expectancy. And then function-first interventions. We have to engage our colleagues in allied health in our plans, more to enforce more strength, balance, and mobility interventions. And those in collection is the true essence of comprehensive geriatric assessment, which is a dynamic process. It's a dynamic diagnostic and therapeutic process that never ends. It continues with the patient wherever they go, whether to see a physician or a physiotherapist or a clinical pharmacist or a social worker. We should always focus on removing harm, especially when the deficits have accumulated already and the patient is reaching the moderate and the severe frailty stages. So what happens if we get it right? There has been some studies and some centers that have took initiatives to implement that, and it's really promising. And it's consistent across all those papers or studies that falls can be reduced to about 30%, which is a huge number. Most of sworn by medications now does not actually reach that percentage even. Medications-related harm can be reduced by a quarter. Hospital admissions can be reduced by 20%, and imagine how much money we save and how much adverse events we prevent from that. And actually, for the functional outcomes significantly improve, especially in patients with mild to moderate frailty or moderate to severe. They didn't reach yet to the full institutionalized status or bed-bound status. Moving to our practice here in our beloved country, there is no doubt there is a huge momentum now that we have to take advantage of. And the momentum is governmental, private sector, everywhere to implement more value-based and value-based care for geriatric population. And we can do that. I don't think it's hard to do. There are some challenges, but hopefully we'll get to it if we start now. Realistic, scalable approach, starting with the high-risk patients at the primary care level. Use a very simple triggers to initiate the process, like high fall risk or a fall that has happened, polypharmacy, as Dr. Amber said. Frailty assessment should be embedded in our system for assessments as vital signs. And then we move forward to more collaborative care and system-based process where the patient will go through the channel if screen positive for any of those. That would lead to clinical pharmacy intervention, geriatric multidisciplinary team approach with assessments and plans, and then going back to the primary care. This will help us, if we do it right, to build pathways, not parallel systems that they don't talk to each other, and the patient gets frustrated and less trustworthy of or less trusty of the system, and hopefully we can prevent that syndrome from happening. The final message that I want to say, and before moving to more discussions, is that in geriatric care, especially with patients who are frail, who have entered already the frailty role, we should focus on safety rather than targets, or put the safety and clinical or functional level or functional impact as a priority rather than targets, and focus on the disease itself. And we should move from intensity to appropriateness. Falls are not inevitable, we can prevent them, and they often they are often actually the result of how we deliver care and how we either miss risk stratification or intensify our treatments. Going back to our beloved lady here, I wanted to bring this to your attention and to implement on our case, which is the Stopping Elderly Accidents, Deaths and Injuries Initiative, or STADY initiatives, which has been created, adopted by the Centers of Disease Control and Prevention in the US, and then eventually to be more adapted globally. And even here in our country, Wakaya and the Ministry of Health are trying to collaborate and to implement this on the primary care level, also on a secondary and tertiary care levels, which is basically starts with screening all patients, all geriatric patients, with the simple 12-question tool, and or the three questions tool. And then if they screen positive, we go through the full risk assessment and intervention, whether they had the fall or not, or they have high risk of fall, which includes the evaluation of gait, strength, balance with the tests that you know, identify the medications that can increase the risk using the Pierce criteria, stop, start, assess the potential harm at home, and measure the orthostatic vitals, and also the glucose monitoring, check the visual acuity and hearing assessments, assess for foot and footwear integrity and safety, assess vitamin D and the bone health status, and also check for other comorbidities that can impact fall risk. And then we implement or intervene as addressed, either with physical therapy, fall prevention program, or exercise as Tai Chi, medications reconciliation, try to make it as appropriate as we can. Home hazards likely can be checked, or either through social system or occupational health, orthostatic hypotension addressment, and also the visual and hearing or sensus optimization intervention, and eventually making sure that the bone health is optimized to prevent fragility fracture, and make sure the patient is wearing a footwear that is actually safe with a good heel support, etc. And then we move forward to the follow-up, 30 to 90 days after, and measure the risk, where is it, how the patient is doing, how their functional status is, and continue that dynamic process. From the case, if we apply that, there are some intrinsic factors, as you see: advanced age, frailty, sarcopenia, osteoarthritis, neuropathy, visual impairment, cognitive decline. All this is just from the history. And then when we move forward to the medications, you can see there is amitriptyline, there is some diuretic nocturia, there is some polypharmacy, insulin might be related to the hypoglycemia, especially at night when the patient is not eating, orthostatic hypotension, and you go through all the lists that we can just pick on, address, prevent that incident from happening, and hopefully improve the quality of life, the functional status, and also save money to our healthcare system. At the end, I thank you so much for this opportunity. The future of cardiometabolic care, I see it as I see it now from all the parties, societies involved in all of the adults and in those chronic disease management, is actually moving towards not doing more, to more doing what actually matters safely. Thank you so much. That was my presentation.
يعطيك العافية. Thank you so much, Dr. Al-Amri. It was excellent presentation, very practical with the different pathways that can be implemented in our system. طيب, I think now we're going to move to the question and answer session. After that, we're going to have our last speaker. We're going to talk about initiatives. So it's open now, the floor for any question. You can write your questions, or you can open the mic whenever you are ready. I have a question, Dr. Amber, if you allow me. From your experience, you know, it's in the clinic. Dr. Zulfaqar, are you with us? Dr. Amber? I think we lost her. Okay, Dr. Suhail, if you allow me to ask you, from your experience, what are the main the multidisciplinary pathways that is practical and you have tried in your clinic, in your disciplinary, to prevent falls either in patients or even outpatients? Oh, Dr. Amber is here. So Dr. Suhail, you can answer, then we can go back to Dr. Amber.
Sure, thank you so much. I would say from the Saudi practice, and let's focus on our national field, there has been great initiatives from Ministry of Health for implementing age-friendly systems and promoting them in our medical field. Thanks to the Ministry of Health and to the therapeutic deputies, and also to Dr. Walid, who was putting great effort, and his team also in this. So again, making the risk stratification and the assessments and the interventions more systematic rather than personal efforts scattered here and there. So making the policy inside the facility, how we gonna assess for fall, and if that fall risk is there or the patient has already fallen, what we gonna do next. Then identify the parties, the team members who gonna intervene and what they're gonna do, what's their assessments and what their scope of practice. And then how are we gonna follow on this going forward. I think we have some success stories that we have already achieved. I'm not going into further details about that. Age-friendly system data has been shared through the Ministry of Health annual report. And in my facility where I was practicing, we were able to reduce the risk fall to the kind of usual anticipated numbers just by implementing that. There will be a physician who will be asked to assess the patient whenever there is a fall or a high fall risk, and that would follow with the other multidisciplinary team, specifically to the rehabilitation services, make sure the patient has access to senses assessments like hearing and vision, and apply aid if possible, and make sure that we have checked the bone health and we did the medication reconciliation. Only by doing that as a simple kind of initiative, baby steps changes, we have achieved great numbers. So imagine if this is a system-based autopilot thing, that is in all our tertiary hospitals and primary care centers. This for sure will have a huge positive impact in our elderly health and healthcare system economy, sure.
Yes, I agree with you, Dr. Sohail. It's really important to have that national pathways to be implemented in the primary, secondary, or tertiary. Dr. Khalid, yes, you can open the mic and ask.
Assalamu alaikum. Thank you for the great talk, Dr. Dhul Fiqar, Dr. Sohail. I have a quick question regarding polypharmacy to you, Dr. Dhul Fiqar. We conducted a research study that was done 2 years ago and was published at BMC Geriatrics, and we found that the prevalence of potentially inappropriate medication in our region was around at least 50%. So basically, older adult older than 60 in the community settings, 1 out of 2 have polypharmacy, and the most reported potentially inappropriate medication was antihypertensive / antiplatelet, anticoagulant. Those were the very most common medication were reported to be potentially inappropriate. Also, I have noticed that there were many problems in the process of deprescribing. What do you suggest as on a national level, on a system-based level? How can we mitigate this problem? How can we help solve those problems through either virtual visits or what's your suggestion?
Thank you so much for the question. So I would give different examples. So just like what was earlier being discussed, it depends on the setting, even in US where you are practicing. So I have practiced both as a family physician, as a geriatrician. So one of the clinics which you are aware of as well was a Center for Healthy Aging. There, the way the clinic was set up was very different. And what Dr. Smari was talking about earlier, Almari was talking about earlier, is a lot of systems which were put in place. One of the most important was comprehensive geriatric assessment. And there were team members who were practicing under the same roof. And this is as in a primary care setting with geriatric clinic. So we had our psychiatrists, we had our social workers, we had our own home health program there. We could consult the pharmacists. So I have, in my practice, I've seen that comprehensive geriatric assessment on every frail adult who comes in is something which gives us a lot of information. And that actually is then we are able to then identify which pathway. So like what was discussed earlier, if somebody comes in, they have fall, right? So every geri assessment would ask the question that if the patient has had a fall in the last 6 months, and as soon as we find that out, we follow the pathway for what is going to happen next. So one of the things to answer your question is using comprehensive geri assessment, and then knowing your resources is very important, because see, as geriatrician, and we know that here in US also there are very few of us because it's our passion. We are not paid as much as the other specialists. So whoever is in it has a passion for it. So I would say training at a very medical school level, making sure that students and young physicians are aware of the problems related to the geri population, and working together as a team. That's very important.
Wonderful. Thank you so much, Dr. Zulfiqar. We have 2 questions. So from Dr. Fadi, if you allow me to read it, is there any evolution for fall prevention that can be used as an assisted device to prevent falls in elderly, especially those with cognitive impairment? So either one of you can answer it, either from the United States perspective or in the Saudi Arabia. Do you have any experience with any technology that can be used?
The experience, I'm not an expert in AI and using technology in fall prevention, but I will just reflect on the experiences I had during my training in Canada and also the practice here in Saudi. So let's divide the technology in falls into 2 categories. So the fall prevention and the alert system when the fall happens. So in the category of fall prevention, it's very promising. It's still evolving. I would say that the most advanced technology in that entity is in smart home implementation, where you can actually, in the new settings of architecture and home constructions, you can implement smart home system that can have features either through some modified rays or vision changes that can actually detect any dizziness or unsteadiness in the house, especially if the patient they themselves cannot report that. Still developing in the sort of fall prevention rehabilitation is the entity of virtual reality, where the patient will be put into a VR eye glasses or so, or a machine, and they run scenarios of falls based on the history they have and based on their home environment. Hopefully by this we can create some virtual reality rehabilitation so the patients in real life can avoid that fall. In regards to the medical alert system, it's more advanced than the falls prevention technology. I'm sure that you have all come across the medical alert systems, which can be either a devices that the patient can wear on their necks or hang on their or medical bracelets, or in these new smartphones as mobile apps that would trigger the or watches, smart watches that would trigger a medical alert pathway either through EMS or through an emergency contact or a family member, beloved one, spouse, etc., to alert that that person had actually fallen down and we need an urgent assistance, either by direct calling or by just GPS location and sending the help there. So this is my experience that I have come across so far. I'm not sure if Dr. Zulfikar would like to add any to that too.
I agree with you, Dr. Suhail. It's very promising technology, and hopefully in the future we're going to have something evidence-based for that. Dr. Zulfikar, if you're going to add something about this?
Yes. So that's $1 million question, right? What were you talking about? But I'm actually currently involved in a study which is using transcutaneous neurostimulation, the ones which we use for psychiatric patients as well who have resistant depression. And this study is actually right now being conducted on Parkinson's patients who have balance issues, or they're also recruiting people who are a high risk for falls. And they're actually trying to see if that non-invasive neuromodulation can help in reducing falls by working through more, control over the balance. So I'll keep you guys updated.
Yeah, very interesting study. Hopefully we're gonna hear something new. Thank you so much. I think we're gonna conclude because we're gonna have our last speaker. Thank you so much, Dr. Zulfikar. Thank you so much, Dr. Al-Amri. Dr. Khalid, so we're gonna have our last speaker now. Yes.
Yes, we're gonna have inshallah last speaker, Dr. Jum'a, with us today now.
Yes.
الله يحييكم. السلام عليكم.
السلام عليكم ورحمة الله وبركاته. حياكم الله دكتور جمعة.
الله يحييكم.
I would like to introduce you, Dr. Jum'a, before you start your speech. Dr. Jum'a Al-Anizi, he is from صندوق الشهداء. صندوق الشهداء are basically doing now an initiative called شحم الوفاء. It's basically for the family members of those who were involved من الشهداء من ذوي الشهداء والديهم وغيرهم in a patient care, and he would like to give us a brief about their initiative. تفضل جزاك الله خير دكتور جمعة.
شكرا جزيلا. Do you want us to talk English, Chinese, Japanese, Tagalog, or Arabic?
لا عربي. I think عربي will be fine.
الله يحفظك جزاك خير. شاكر لكم حقيقة. يعني I do appreciate actually this annual conference from the Geriatric Medicine, and thanks for the organizing committee. Thank you all actually. راح ابدا باللغه العربيه حقيقه لانه في emotional statements I wanted to say it actually during my presentation ان شاء الله. If you allow me, I want just to share my presentation.
شور دكتور جمعة تفضل.
بس احتاج احد يساعدني في الشيرنج. اوكي الان شير. اتمنى انها تكون واضحه السلايدز.
واضحة الآن الله يعافيك، كبر بس لو سمحت.
ابشر. لعلها
تفضل.
واضحه الان.
واضحة، تفضل يا دكتور.
إذا أذنتم لي، أنا أتحدث إلى أكثر من 200 حاضر ما شاء الله تبارك الله في هذه الجمعية أو في هذا المؤتمر الرائد لجمعية طب كبار السن. أنتم تساهمون في تحقيق رؤية المملكة 2030. غاياتها اقتصاد مزدهر ومجتمع حيوي ووطن طموح. فغالبا الأعمال هذه اللي سمعتها اليوم، وأنا سعيد جدا أني مشارك معكم من الساعة 1 اليوم، وسمعت كثير من المداخلات والمحاضرات القيمة، هي تساهم في إيجاد المجتمع الحيوي ليس فقط للمجتمع بصفة عامة، وإنما لفئة غالية جدا، فئة غالية جدا، وهم كبار السن حقيقة، ممن تجاوز ربما 60 70 80. والميزة في هذه الجمعية أنها تخدمنا نحن الأعضاء، فنحن من خلال عقد أو عقدين من الزمان سنكون من هذه الفئة. فأسأل الله سبحانه وتعالى يبارك في جهودكم. أنا أقول عندما تجلت رؤيتنا بصدق ووضوح، وتولى زمامها ذو الشغف والطموح، وانتشينا من مبادراتها عطرا يفوح، وبدت مؤشرات الخير في الأفق تلوح، فنحن في اقتصاد مزدهر ومجتمع حيوي ووطن طموح. لو سألت سؤال أحد يعرف عن صندوق الشهداء والمصابين والأسرى والمفقودين، ربما أبغى أستغل الوقت لأني لو انتظرت الإجابات ربما أخذ فترة طويلة. صندوق الشهداء والمصابين والأسرى والمفقودين يعني بدأ في خدمة هذه الفئة الغالية بقرار من مجلس الوزراء، ومن خلال 3 سنوات ماضية رأس مجلس أمنائه سمو سيدي ولي العهد، وبعضوية وزير الداخلية ووزير الدفاع ووزير الحرس الوطني ورئاسة أمن الدولة ووزير الموارد البشرية وأيضا وزير المالية ووزير الشؤون الإسلامية، وأربعة حقيقة من كبار رجال الأعمال الأفاضل الذين كانوا أعضاء في مجلس الأمناء. ويرأس حقيقة الصندوق، صندوق الشهداء، سعادة الأمين طلال بن عثمان المعمر. ونبدأ في خدمة هؤلاء الشهداء، أسر الشهداء من والدين وزوجات أو زوجة وأطفال، وكذلك المصابين أنفسهم ووالديهم وأبنائهم وزوجاتهم، وكذلك الأسرى والمفقودين. إذا أذنتم لي هذه الكلمة من خادم الحرمين الشريفين الملك سلمان بن عبد العزيز آل سعود، نفخر بشهداء الواجب والمصابين الذين ضربوا أروع الأمثلة في التضحية والفداء من أجل العقيدة والوطن، ونؤكد على أن أسرهم ستظل دوما موضع عنايتنا واهتمامنا. الأمير محمد بن سلمان حفظه الله ولي العهد ورئيس مجلس الوزراء، وكان خلال 3 سنوات الماضية هو رئيس مجلس أمناء هذا الصندوق، دعما له قال عبارة جميلة أصبحت سلوغان عندنا، احنا أصبحت شعار عندنا: الراح منكم أب أو أخ أو ابن، الملك وأنا والشعب السعودي يسد محله. يسد محله، نبغى نسد محله ما دام ندافع عن وطننا، ضحى بنفسه أو ضحى بحياته أو ضحى بجسده أو انجر أصيب لأجل حماية الوطن وحماية الحرمين وحماية قادة البلد وحمايتنا، حماية مساجدنا، حماية مدارسنا، جامعاتنا، مستشفياتنا. فكان يستحق حقيقة هؤلاء أن نخدمهم، وسوف نركز إن شاء الله أيضا على كبار السن وكيف نهتم بهم، وأيضا ندعو إن شاء الله الأبطال الشهماء الموجودين حاليا أن يكونوا مساهمين في خدمة هؤلاء. هذا القرار هو قرار مجلس الوزراء رقم 366 بالموافقة على تنظيم الصندوق، والذي نشأ بموجبه صندوق يتمتع بالشخصية الاعتبارية، ويهدف الصندوق إلى عون ورعاية أسر الشهداء والمصابين والأسرى والمفقودين، ومساعدة المحتاجين منهم ومن يعولونهم شرعا، والقيام بأعمال خيرية يعود أجرها وثوابها لهم. رئيس مجلس الأمناء الحالي اللي تشرفنا فيه حاليا اللي هو صاحب السمو الملكي الأمير خالد بن سلمان بن عبد العزيز آل سعود وزير الدفاع، والعضوية الأعضاء السابقين سمو وزير الداخلية، سمو وزير الحرس الوطني، معالي الشيخ الدكتور عبد اللطيف آل الشيخ، وأيضا وزير المالية، وزير الموارد البشرية، ورئيس أمن الدولة، وهناك أيضا 3 أعضاء من كبار رجال الأعمال. الرابع توفى رحمه الله سبحانه وتعالى، وهناك بحث عن إضافة بديل إن شاء الله. هذه اللجان التنفيذية التي تتابع أعمال الصندوق: لجنة تنفيذية يرأسها وزير الداخلية، لجنة المراجعة يرأسها وزير الحرس الوطني، لجنة الاستثمار وتنمية الموارد يرأسها وزير المالية، ولجنة الترشيحات والمكافآت يرأسها وزير الموارد البشرية والتنمية الاجتماعية. الشهيد له تعريف: الشهيد من توفي من العسكريين أو المدنيين بسبب الحرب مع العدو، أو أثناء التمارين العسكرية وحفظ الأمن، أو أثناء عمليات إنقاذ الأرواح أو الممتلكات في حال الاحتجاز. يشمل ذلك الطلبة العسكريين الذين يكلفون بمهمات مماثلة، وكل موظف عام عسكري أو مدني أو متعاقد توفي بسبب أعمال إرهابية أو بسبب استهدافه بقصد الإساءة إلى المملكة. ويدخل في حكم الشهيد من كانت إصابته أكثر من 70%. المصاب من أصيب من العسكريين أو المدنيين بعجز نسبته 70% فأقل بسبب أيضا الحرب مع العدو، وأيضا تضاف أسرته معه. الأسير هو العسكري الذي يحتجز قسرا بسبب الحرب مع العدو أو أثناء التمارين العسكرية، ونتثبت أسره خلال 6 أشهر، ويعامل معاملة الشهيد كأسرة كاملة، جميع الخدمات تقدم لأسرة الشهيد. وكذلك المفقود أيضا ينتظر 6 أشهر من فقده بسبب الحرب مع العدو أو أثناء التمارين العسكرية، وأيضا تعامل أسرته معاملة الشهيد بعد مرور 6 أشهر. من هم المستفيدين؟ Our beneficiaries: الأب والأم، الزوجة، من يعولهم شرعا، والأبناء، والمصاب نفسه لأنه حي يرزق ولكنه في إصابة وأحيل إلى التقاعد أو فصل من الخدمة العسكرية بسبب الإصابة في الدفاع عن الوطن. منصة شهم: احنا انشأنا منصة اسمها شهم. من هو شهم؟ شهم هو الشهيد، شهم هو المصاب، شهم هو الأسير، شهم هو المفقود، شهم هم أسرته، شهم قيادة البلد، شهم الأبطال، شهم الأطباء المساهمين في خدمتهم، شهم المجتمع. فقلت والله كلمات: شهم كما راية التوحيد مقدام، شهم إذا ما اقتضى للأمر إقدام، أبطالنا فخر أهليهم، وقادتنا هذا اعتزاز، وفي الأعماق إكرام. شهم المنصة عندنا شهم تواصل أهليهم وتسعدهم، حياتهم منهج بالعز إسلام، وفي المهارات والتطوير منهجهم، تمكينهم دائم في الخير إسهام. شهم هي العبارة اللي أنشأناها لمنصة إلكترونية تربطنا مع القطاعات العسكرية والأمنية لتسجيل المصابين والشهداء والأسرى والمفقودين، وهي منصة لبيانات المستفيدين نسجل فيها بيانات أسرهم، ثم نقدم لهم الخدمات، جميع خدماتنا. أنشأنا الله يحفظكم جميعا منهجية علمية دولية هي مصفوفة التدخلات التنموية، نقيس فيها الأسر، وعندنا عدد كبير جدا من الباحثين يذهبون إلى الأسر ويشوفون. عندنا مقياس مكون من 5 ليفل اللي هو ما يسمى بالليكرت سكيل، ولكن رقم 1 هو مهدد، 2 في أزمة، 3 آمن، 4 يبني قدرات، و5 ممكن. فنشوفها على مجال جودة الحياة، على البرامج السكنية، على التعليم والتدريب، على خدمة الصحة، على جودة الحياة، على الوعي المالي، على الصحة العقلية، الصحة البدنية، وهكذا. فيقاس من 7 أبعاد و16 محور من محاور الحياة، ونشوف من هم المهددين وفي أزمة، ونبذل بتصميم برامج متعددة للتدخلات من أجل تمكينهم وعنايتهم ورعايتهم وتكريمهم بإذن الله تعالى. أيضا أصدرنا بطاقة شهم لكل واحد منهم، تنزل لهم في بطاقة توكلنا لتعريفهم عندما يأخذون بعض الخدمات من الجهات الشريكة ذات العلاقة. هذه استراتيجيتنا. الغاية نريد أن نعمل تمكين مستدام واعتزاز عميق وحياة عامرة لهؤلاء. أتمنى إن شاء الله أن صوتي واضح والسلايد واضحة.
واضح حفظك الله دكتور جمعة، وأنا أشكرك على هذا السرد، ولكن أتمنى أنك في آخر 5 دقائق متبقية أنك تركز لنا على الجانب الطبي، وكيف ممكن فعلا حنا نساهم في خدمة ذوي الشهداء والناس اللي لهم فعلا حق علينا.
الله يحفظك ويبارك فيك. سريعا: الغاية، الرؤية، الموذج في التمكين وإجادة في التكريم ومثال في الاعتزاز، ونسعى لركائز نوفر لهم حياة عامرة، ومن خلال أيضا مجتمع متفاعل. أذهب إلى شهم الوفاء. أطلقنا الله يبارك فيكم مبادرة سميناها شهم الوفاء، وعندنا قبلها مبادرة اسمها شهم كير، وهي عبارة عن منصة إلكترونية يدخل فيها الأطباء يقدمون خدمات استشارية من خلال شهم كير بسرية بخصوصية تامة، وجميع الممارسين الصحيين مرخصين من الهيئة السعودية للتخصصات الصحية ومن وزارة الصحة، ويقدمون الخدمات للمستفيدين من خلال جلسات يتم حجزها من خلال مواعيد. أنطلق الآن من شهم كير. احنا نسعى لخدمة كبار السن من خلال مسؤولية الصندوق تجاه هذه الفئة، وأنتم أعرف من عندنا الآن بالقرارات الصادرة بأهمية رعايتهم والاهتمام بهم بصفة عامة ومن الناحية الطبية بصفة خاصة. فدشنا مبادرة شهم الوفاء التي تهدف إلى تحسين جودة الحياة الصحية والنفسية والاجتماعية عبر تدخلات مهنية منتظمة وخطط رعاية فردية. هم بركة الحاضر ومنارة المستقبل لأجيالنا. نحن نعمل وفاء للماضي لما عملوه واستثمار في حكمتهم ورعاية تحفظ الكرامة وخبرة تبني الأجيال. الجانب الطبي هو واحد، هناك عدة مسارات من ضمنها زيارتهم ودعمهم، وأيضا أخذ قصصهم عن أبنائهم وعن من ساهم، وبعضهم هم أساسا من المصابين الذين دافعوا عن الوطن في معارك سابقة أو في حالات سابقة. مبررات إطلاق المبادرة ارتفاع الاحتياجات الصحية لهذه الفئة، واليوم ذكرت يعني إيفيدنس كثيرة جدا عن هذه الفئة. زيادة احتمالية العزلة الاجتماعية، الحاجة إلى متابعة دقيقة ومنتظمة، وتعزيز الاستقرار النفسي والمعنوي. كذلك وفاء بمسؤولية الرعاية المستدامة. الرعاية الصحية نحن بحاجة حقيقة للاعتناء فيهم. أنا لا أخفي سرا أن عددهم عندنا ممن يصل عمرهم إلى من 80 إلى 115 سنة يتجاوزون 500 في الفئة في المجتمع الصغير اللي عندنا، وهؤلاء حقيقة بحاجة إلى رعاية وإلى برامج حقيقة نأخذها من المتخصصين أمثالكم بإذن الله. فحوصات دورية، متابعة علاجية، رعاية منزلية. برضو كذلك عندنا الدعم النفسي والاجتماعي من خلال جلسات دعم فردية، لقاءات اجتماعية شهرية، وزيارات منزلية عند الحاجة. فهذه حقيقة احنا بدأنا ونبدأ فيها بإذن الله تعالى. ودي أتكلم معكم عن جمعيتكم المباركة التطوع الاحترافي في منصة شهم كير. ممكن تدخلون معنا من خلال شهم كير الأخوة ويتطوعون بساعات معينة، ربما تكون ساعة كل يوم، ولا تكون ساعتين كل أسبوع، ولا تكون 4 ساعات كل شهر، بس تحدد كبرنامج. وثم يدخل كبير السن ممن احنا نتواصل معه من خلال المنصة ومن خلال ذويه، ويأخذ الاستشارة. ربما نضيف قيمة وجودة لحياته. المنصة معتمدة من وزارة الصحة كمركز طبي اتصالي، ومن وزارة الموارد البشرية والتنمية الاجتماعية كمركز إرشاد أسري يقدم خدمات صحية واجتماعية لمستفيدي الصندوق. منهجية العمل جلسات تتبع منهجية العلاج الصحي والنفسي والاجتماعي، وتتضمن تقييم قبلي وبعدي لضمان تحقيق المنفعة والقيمة للمستفيد، وهي تواكب منهجية محاكية للواقع العيادي في الجلسات. الجلسات تتضمن تقارير تشخيصية واجبات من قبل المعالج وتسجل من خلال ريكورد، وأيضا كذلك تحديد البرامج والرحلة العلاجية بعد التشخيص من قبل الممارس الصحي. بكل أمانة لماذا تتطوعون معنا؟ وأنا واثق إن شاء الله أنكم أيضا ينطبق عليكم كلمة شهم، والصندوق يعني إن شاء الله يفخر بوجود شراكة مثل مع هذه الجمعية المباركة اللي فيها عدد كبير جدا من الأطباء المختصين والممارسين الصحيين في مختلف مناطق المملكة، ومستفيدين موزعين بكل مناطق المملكة، في حايل، في الشمال، في تبوك، في عسير، في جازان، ولنا زيارات أيضا لهم مستمرة. فهو رد الدين المجتمعي لأبطال الوطن وأسرهم، نظير دفاعهم وبطولتهم. أيضا الأثر المباشر في تحسين حياتهم النفسية والصحية ورفع جودة حياتهم. وأيضا توثق الساعات للمتطوع تطوع احترافي من خلال عندنا منصة هي المنصة الوطنية للعمل التطوعي، وكذلك المرونة العالية، فيحدد الوقت المتاح له بما يتناسب مع الجدول العملي وتقديم الجلسات عن بعد. هذه تقريبا فكرة المبادرة، وانطلاقتها قريبة من أسبوع أو أسبوعين، وبإذن الله ننتظر حقيقة المشاركين بإذن الله. إذا سمحتوا لي أي مجال للسؤال، ولكن عندي أيضا استبيان. ممكن الموجودين الآن كل واحد منهم يطلع في فكرة أو لو أنها عبارة واحدة تساعدنا في بناء تصور مستقبلي من خلال خبرتكم ومن خلال عملكم باذن الله تعالى.
بوركت
الله يبارك فيك.
بوركت دكتور جمعة، وبإذن الله يحرصون الزملاء الأفاضل. شهم كير بلا شك هي مبادرة تطوعية جميلة. اللي فهمته منكم سعادة الدكتور أحمد أنها لها خدمات صحية علاجية، ولكن أبغى أعرف هل هي تبلورت هذه الخدمات، أو نحن بصدد الاتفاق معاكم إن شاء الله وعمل مذكرات تفاهم للتعاون وإعداد مثل هذه البرامج لذوي الشهداء. تقول ذوي الشهداء من كبار السن ما يقارب 500 في هذه الفئة، عدد ليس بالبسيط وبلا شك منتشر في جميع أنحاء المملكة. أعضاء
نعم.
الجمعية الأكارم باسمهم جميعا يشرفنا بلا شك خدمة هذه الفئة الغالية، كلا بحسبه، كلا على حسب قدرته. ولكن كذلك من جانب علمي نستطيع خدمتكم بتأهيل برامج وإعداد برامج نوعية لمثل هؤلاء المحتاجين من كبار السن بحكم التخصص. جزاكم الله ألف خير.
الله يبارك فيك ويسلمك، وهذا حقيقة ما نسعى إليه. احنا متوقعين من خبرتكم العلمية ربما تكون هناك مناهج كبيرة جدا لفوكس جروبس، لزيارات منزلية. ممكن احنا عندنا زيارات مستمرة لهم في المناطق، فممكن يرافقنا حقيقة عدد من المتخصصين لزيارتهم أثناء وجودنا في هذه المناطق بإذن الله تعالى. ولكن ما نستغني والله عن تصوير الباركود، ولو عبارة واحدة تضيف لنا قيمة كبيرة جدا من هؤلاء المتخصصين الأفاضل الموجودين معكم في هذا المؤتمر الرائع.
بإذن الله تعالى أترك المجال للزملاء الأفاضل في مداخلة أو مداخلتين قبل ننهي اللقاء.
السلام عليكم ورحمة الله وبركاته. شكرا
عليكم
دكتور
السلام.
جمعة. أسأل الله العظيم أن يوفقكم ويسدد خطاكم ويعيننا وإياكم إن شاء الله على تقديم ما فيه الخير لهذه الفئة الغالية.
آمين.
حبيت بس أنوه من موقعي يعني رئيس لجنة العلاقات العامة أن نرحب دائما بالتعاون مع جميع الجمعيات المعنية بخدمة كبار السن، سواء الجمعيات العلمية أو الجمعيات الخيرية، ويسعدنا أن نقدم الدعم العلمي والإسناد العلمي لجميع الجهود سواء الحكومية أو الخاصة أو التطوعية. أحب أيضا أن أنوه على يعني أهمية مشاركة الجميع. أشيد بالحضور اليوم، الصراحة كان مسعد لنا جميعا، وأشد على أيديهم بالدخول على الرابط اللي حطيته في وصف أو في المحادثة، صندوق المحادثة اللي هو رابط الجمعية. أشيد ويعني أهيب بالجميع أنهم يسجلون كأعضاء في الجمعية لكي نتمكن من التواصل والتعاون، وسواء في مجالات المبادرات اللي إن شاء الله بنعملها في المستقبل، أو حتى في إن شاء الله إذا بدأنا ننخرط بشكل أكبر في موضوع تنظيم التطوع الصحي والمبادرات التطوعية. I hope everyone attending today will have a chance to go through the link to sign up a membership to the Saudi Geriatric Society. We are really appreciative of everyone and their efforts to collaborate in providing more scientific support to all societies and sectors in the country, whether they are government, private or semi-private or non-beneficiary sectors, to provide scientific support and or leadership support. وجزاكم الله خير. هذا ما عندي. شكرا لك دكتور جمال.
شكرا لك، الله يعطيك العافية. شكرا، فخورين فيكم والله.
شكرا جزيلا للجميع. بالنسبة للزملاء اللي عندهم مشاكل في الإيميل، تواصل معنا على الإيميل saudi-geriatrics@gmail. وجزاكم الله ألف خير جميعا. شكرا دكتور جمعة، الله يحفظك.
الله يحفظكم وشاكر ومقدر. بارك الله فيكم.
الله يحفظكم. السلام عليكم.
مع السلامة.
Recording stopped.